number of children with hyper ADHD has been increasing, as you can see here. But the point is whether the child has autism, whether the child has ND, whether the child has ADHD, whether he has subnormality, the clinical symptom that they come to you with is very often this child is very hyperactive. Is that right? So rather than focusing on the diagnosis, we are going to focus on the clinical approach to it. So this is the first case. A 4-year-old child comes to your OPD for cough, cold, fever. Mother said, please start an antibiotic immediately because I have already received a lot of problems in the stool. Is this working or not?
Yeah, it's working. Sorry, yeah, go ahead. Yeah.
No, that's okay. I'll do it and I'll get confused. So, when you ask the mother why you so worried to start an antibiotic right away, I have received many complaints from school and I don't want to run into any more issues. So you ask the mother what kind of complaints. So what do you think are the kind of complaints that you must be getting in this class?
We don't know many concepts.
Some doesn't sit in the class. Yes. Disturb the class. Very good. Bully. Child bullying others. Running in the class. Restless in the class. But what does the history tell you? Of cold and fever. Who said anything about hyperactivity? Who said anything about developmental disorders? So everything is not about. Oh, this is really horrible. I'll stand here and do it. That's okay. If you do it, if both of us do it, it won't work. So the whole idea is just because a developmental pediatrician is talking, doesn't mean everything is developmental pediatric. So don't be in a hurry to judge or label. And this is the whole idea of this talk. Don't put something in a compartment, don't stick a label to it. So it is not necessarily developmental pediatrics. You have to ask what kind of complaints. The complaint can be the child is coughing every day. The complaint can be the child is sneezing every day. It can be allergic rhinitis. So what is very important is take detailed history. And in that case, the mother says, yes, when the school counselor told her child is not doing well, the child is rather hyperactive, but he does seem to learn what is being taught like other children. So this is what I call, the teacher says he does not seem to have a learning difficulty. All these degrees are given very easily nowadays in school. Have you experienced that? Parents come and tell you, teacher said my child has autism. Teacher said my child has learning disability. Have you heard that? Very often. So the point here is this is a child who's hyperactive. But since we are all pediatricians, we like the word thriving. What we are trying to say is learning well. He's not lagging behind. Now, when you go ahead with this child, what will you advise? Refer the child to an occupational therapist, or refer the child to a psychologist, refer the child to a developmental pediatrician, or start medication. What will you say? Evaluate by yourself. Sorry, just evaluate by yourself. Excellent answer. First, evaluate by yourself. That is the most important, correct answer. Don't rush to do any of these things. Don't get worried, and that's why the message is don't be yourself, don't be hyper about activity. Just calm down, relax. Don't get excited too much like the child. So you're absolutely right, sir. Don't do any of this. Use your own pediatric knowledge. So don't be hyper about activity. So what is your advice? Assure the mother I do nothing. Nothing is wrong. That means his heart is functioning well, no. His lungs are normal. His POT is okay. Don't worry. Generally, this is what is seen, or you have seen some post on Instagram or Facebook that give the love to the child, accept the child, don't blame the child. So you give some glib yarn like that and you bypass it. Which of these two do you think is right? So who has time to talk about all this? It'll be okay. All this better to do. So even this is not good. So I call this very hypo about activity. Some pediatricians don't want to do anything else. Even that is not very good. But what is important is, like he said, you have to be Sherlock Holmes yourself. You are curious and you will ask for details. And hence, ask the mother more questions. So this is what the mother comes back 2 days later and tells you. She asked the counselor who said, child is hyper for the first half an hour of the class and then settles down. 4-year-old child. Then he settles down. Now what is it? It's okay. It's not. Yes?
It's just getting adjusted.
Yes, getting adjusted to it. Yes, anything else?
Is it the same in all settings?
Is it the same in all settings? That's a good question. Yes? Sorry.
That's the teacher change.
That's the teacher change and cause a problem. Fine. So this is the first situation. I agree to all that you have said. more or less this is normal. Another situation. The child has been hyper since day one and continues to be hyper all through the class. Till he is taken out to the play area, then he calms down. That's the first situation. What do you say? He's throughout the 2 hours, 3 hours, he's in the classroom, he's hyperactive. He has to be sent out to the play area, then he calms down. Now,
If play and with my
4-year-old, you still say, okay, good. Yes, sir.
make him play and take up with.
Make him then come to the class. Absolutely right. This should be also remembered by professors in medical colleges. So in comes also, this is fine. The last situation, child has been hyper since day one, continues to be hyper through the class and gets worse in the play. Now what will you say? Can you see the difference in the three situations? That's my first point to all of you as practitioners. Can you see the difference? Just by asking this one question, like you said, in different settings, how is he? And different places, how is he? How long does it take to calm him down? And what calms him down? Just simple questions that you ask. You realize that the first situation is largely normal. He's hyper for the first half an hour, children are excited and they calm down. The second is interesting, that he calms down only after being taken out to the play area. So there is a variation of the normal, and this is very common post-COVID, especially if you see, because children have been at home for the last 2.5 years. They've seen so much bad news on the TV and everywhere else. So they are anxious. So today, if you see, a 5-year-old child is displaying stranger anxiety, or a 4-year-old child is displaying stranger anxiety, because for the last 2-3 years they've been at home only. The first time, the last 1 year that they're coming out, that they're actually seeing strangers. So in a way, stranger anxiety is being manifested at a later age. So he calms down. But the last part that we have to realize is a variation from the norm. Remember these two phrases. Variation of the normal is okay. Variation from the normal is not okay. And we need to do something for this child. So what do we do? Message. The message is, do not be in a hurry or hyperactive to label children as ADHD. Don't label them, because if you go to label, all of them would be labeled as ADHD and sent somewhere and you would not learn. So observe, do not label. You ask the mother more details at home. The child is very active. Everyone loves him. I have no complaint about my child. This is the mother's story. The last child who goes berserk in the play area. When you ask the mother, she says, my child is amazing at home. I have no complaints. He's the best child in the world. What do you say? Please, Miss Madam, loudly. Please. Sorry. So that means at home is okay. What else? Any other thoughts? Sorry.
Some mothers may not admit.
Some mothers may not admit. Familiar surroundings. So some mothers may not admit. So point is, really, don't just depend on one source of history. You may not be sure. Because you know this is a common in India. This is common in India. Everybody, mother thinks her child is the best. Her child, especially if it is a what gender? Male child. Can never do anything wrong. So this is very important to take the history not just from the mother, but also other sources like the school or the neighborhood. Look at what the neighborhood says. So child is active, everybody loves him, but the neighbors also love him. Now what is? Then you can't disbelieve the mother. You believe the mother. Everybody is calm in the neighborhood also. Now what is? So look for trouble in school. What it means is there is trouble in school. There are complaints from school, but there are no complaints at home. There are no complaints at the neighborhood. Means complaints are not everywhere. Complaints are only in one setting. What is that setting? So very clearly, there is no problem. But the problem is in school, question mark. First question, is he really hyper or is the teacher hyper? The second question, what is happening in the school? And don't underestimate all these issues. Sometimes the children nowadays are all raised like nawabs and princes and kings. Nobody says no to them at home. Suddenly teacher may say, why are you doing this? Sit in your place. That itself I have seen nowadays are enough to traumatize children. All our children are becoming American children. Nobody says no to them. Somebody says no for the first time, they want to jump off the building. This is the problem. So make sure that nobody scolded the child, nobody scared the child. More important than that, in many areas of India, children go to school by bus or by a vehicle, somebody else. very often there may be some kind of abuse. Keep it in mind. There could be some kind of physical sexual abuse happening in the classroom. There could be some bullying. So look for problems inside the school, not inside the child. That's the message. Because if there was a problem inside the child, who also have hyperactivity at home, in the neighborhood. So this is a situational problem. To focus on what's happening in school and check that out. Are you getting fine? Is this fine the way we are going? Do you want to theory lecture? DSM, how you have that? No. So you ask the mother more details. What about his friends? Now look at this history. The neighbors are afraid of this child. Nobody wants to call him to a birthday party. Last time they called him to a birthday party, the other children were playing with balloons. He went and cut the cake and ate it also. Somebody else's birthday party. So this is the situation. Nobody invites him to a birthday party. Everybody is afraid of it. Now what do you say? Why? What is the problem? He is not able to adjust anywhere. He is not able to adjust anywhere. Absolutely not able to socialize. But remember the word. What sir said. Adjust. It is not about hyperactivity. Please, this is a very important statement I am going to make, which is very much against what the Americans say. It is not about hyperactivity. If your child is a football player and he goes in a football match and he sits like this. He is the goalkeeper and he is standing like this. Goals are being fast. Very calm child. Lovely child. No, he has to be hyperactive on the football field. He has to be jumping around everywhere. The man who runs the most on the football field is the best footballer. Correct or no? He has to run around everywhere. So is he hyperactive? The same fellow, when he goes to the classroom after playing football, there he sits quietly. Or there also he keeps around, running around while the professor is teaching. He goes around playing football in the class. Is that normal? So it is not about the activity, whether it is hyper or it is hypo. It is about understanding what to do where. Can you repeat that? It's about understanding what to do where, how to regulate myself depending on the situation. How to be a diplomat, how to be a politician. All Indians are very good at that. The regulation is the problem. So it's not about hyperactivity. It's whether the child is able to adjust. And like sir said, if he is able to adjust to different situations, then there is no problem. This child is not able to adjust to any situation anywhere. So the problem is not at school, maybe the problem may be at home itself. So this is a child who is hyperactive at home, neighborhood, everywhere else. So this hyper at multiple places. Even now, don't label the child. First, look at the situation at home. Is this child from a family which treats the child like a prince? Nobody says no to the child. So the child goes everywhere and thinks nobody will say no. Doesn't understand the meaning of the word no. Permissive parenting. Domestic violence, he's seeing so much of abuse, father hitting the mother, alcoholic parent, all this kind of things happening. He's being abused, he's being neglected. So this is the kind of a reactionary behavior. Don't label the child as ADHD and don't treat the child. Look into the situation behind at home. Treat the home. Is this message clear? Don't send this child for therapy right away because it's not going to help him. The situation is outside, the problem is outside. The house hasn't helped him understand how to regulate himself. He hasn't been trained at home how to behave differently at different places. There are children in COVID, post-COVID, who haven't gone to anybody's house, who haven't stepped out of their own home. They're constantly on TV and mobile. They don't know how to behave at other places. Don't blame them and don't treat them. Treat the situation. So again, now going to the other part, if you see the first scenario, hyperactive, learning well, no problem with learning, what are our thoughts? So what will we do? This kind of hyperactivity, look for the home environment, look for the school environment, look for abuse and neglect, recurrent illness that children who have allergic rhinitis, who have allergic disorders, who may be having epilepsy, may be having tuberculosis, they will not be able to pay attention in the classroom. The medications will be making them drowsy. They may not have slept well at night, so they may be drowsy in the classroom. They may manifest as irritability or hyperactivity or poor attention span, but they are not ADHD. Anemia can cause this, very, very important. 50-60% of children in India, especially non-urban India, even in some parts of urban India, are anemic. Very important as doctors take the history of behavior at school, home, and everywhere, not just complaints from the school. And what will we do as pediatricians? The most important thing we do at New Horizons Child Development Center, which is one important, very important secret or whatever you call it, I can share with all of you. Help the parent to sit down and make a timetable for the child. Wake up time 7:30. Brushing teeth, washing mouth, toilet, bath, wearing clothes, small prayer, breakfast, getting ready for school. Write down everything. I'm telling you as a developmental pediatrician, running a developmental center, doing grace of God well, this is what is making us do. It is not some great American technique of therapy that makes us healthy children. This simple thing. And how long does it take? Why do you have to be a developmental pediatrician to explain the schedule to anybody? All of you do that. You can explain this. Second is adequate sleep. One of the most important reasons for developmental behavioral problems are inadequate sleep. Children don't get to sleep, they're staying up late at night. You know the story. Watching television. So very important, adequate sleep. How many hours of sleep should a 4-year-old child get? A 4-year-old child should get 10 to 12 hours of sleep. Point number one. Point number two, how is the sleep divided? How should this sleep be broken up? It should not be broken up. It should be continuous sleep for 10 to 12 hours. That's where the brain relaxes the most. So if you see a child who's sleeping 2 hours in the afternoon and sleeping at 1 a.m. at night and irritable in the morning when he wakes up or wakes up at 9, 10 a.m. in the morning just rushing to school, it's not a good idea. You have to help them understand. Wake the child up at 7:30 in the morning, for example. Don't let the child sleep throughout the day. Don't let the child sleep throughout the day. Automatically the child cycle will get set and will sleep earlier at night. You don't require any medications for this. Outdoor play, I'm sure all of you understand the value of that. Parenting and behavioral management, responsive parenting, understanding the child. If some children are very active in the morning, some children are very active in the evening. If the child is a child very active in the evening, you need to encourage him to go to some place where he can play and not just go and play chess or some kind of singing class in the evening. He would need a physical class. Whereas some children are not very hyperactive, they are calm, but they have an attention focus. This child should probably be sent for table tennis or he should be sent to play chess because you are trying to increase his focus. So this has to be responsive to what the child is telling you. And finally, most important message for pediatricians, monitor this child. Give all this advice, make the timetable, talk about sleep, talk about good diet, talk about stopping media, but ask them to come back to you after 1 or 2 months. And if after 1 or 2 or 3 or 4 months the child is still not better, is still hyperactive, then you need to record this child. Are we fine so far? Everybody? Because this is the largest number of children you will be seeing. The maximum number of children you will be seeing in your OPD tomorrow morning with these problems will be of this category. Going ahead, scenario 2. Hyperactive but not thriving. This child is also hyperactive, but the teacher said he's not learning well. He seems to have a learning disability. Don't go into all those terms. Don't accept those terms. What is the idea? We will go through it in our own approach. So not doing well doesn't seem to learn. He is not picking up things in the school. He is lagging behind other children. So what will we do in scenario 2? What are your thoughts? So to go ahead, messages again inquire and examine in detail and counsel the parents. Don't refer yet. Now you are worried, you go back to details at home. You ask for birth history and you ask for developmental history. What do you think you will ask for in birth history? All of you are the experts. Boye, tell me.
First cry.
Come on, freedom period. Yes, Ajay, come on.
First cry. First cry.
When was the first try? Whether it was uneventful or eventful? Yes, go on. Very good. Very good. What else? That's clearly described whether there were seizures, whether you are all of you are expert in this. Ask better than us, you all are the experts. Developmental milestones. What will you ask in this? Again, whether they are age appropriate or they are delayed. Generally, if they are delayed, they will be of 3 types. Global, what is global delay? Quickly. More than 2 domains. Motor domain also, fine motor also, communication also. Or specific, only speech is delayed or only motor is delayed. Or there is a deviance. The delay is there. In addition, the child has some spinning behavior. It's talking like a parrot, doesn't understand speech, but talks like a parrot. That's a deviancy. You don't expect children to be normally like that. So do you understand the word deviancy? It's not on the normal track. It's not just delayed. It is on some abnormal track by itself. Have you followed? So hyperactive but not thriving well. What will we do? There are 3 scenarios. One is the child has no history of delay at all. Second is the child has history of only speech delay. Third is the child has a history of global development. Let this sink in. If you are really worried about a child who is hyperactive and is not thriving well at the top line, then there are three possibilities. No delay, only speech delay, global developmental delay. Now moving ahead, let's take a child who has no delay. Just little mind delay in speech and all, but not significantly. Scenario 3. He is fidgety, he is impulsive, he has poor attention. At New Horizons, we have come up with a fourth point, which say inconsistent. The mother will say very hyperactive. When you put on the TV, he can sit for 5 hours in one place. Where is the hyperactivity gone? So it is inconsistent, but largely hyperactive, fidgety, impulsive, poor attention. What is impulsivity? Many people have a misunderstanding about this word. What is it? Impulsivity? They don't wait for the terms. They don't wait for their terms. Why? Why is that? Why? What is impulsivity basically? It manifests as not waiting for your turn. But what is impulsivity?
Immediate response.
Inability to
Control your behavior.
inability to control your behavior to able to complete a task. So impulsivity is before you have completed a task, you will leave it and get distracted into something else. You will not be able to control yourself to sit to finish one task. Till then, you will not pay attention anywhere else. Only after that you will pay attention. Impulsivity is do something halfway, something comes along, get distracted, do that, then something else comes in mind, do that immediately. Are you understanding? See the impact. What is the impact of this? You are not able to complete whatever task you are set out to do, whatever you set out to learn. So your learning will always remain incomplete. Your learning will always remain incomplete because you are impulsive. Your work will always remain incomplete because you are impulsive. Fidgety, we can understand poor attention. So take a history, family history. Very often the father or the grandfather or the mother have history of similar thing in the childhood. Take the history from home, neighborhood, school. This we have discussed. In social behavior, play, academics. The problem in India is this. The history will be taken only for academics. Parents will not pay importance to any other history elsewhere. They're not bothered how we behave in the neighborhood. Why? Nobody goes to the neighborhood nowadays. Nobody goes to the uncle's house also, aunties house also, kaka, kaki, mama, mommy, whatever we say, our old terms, nobody goes. This is important. You need to ask them. How is he in the uncle's house? No, that's not important. Mark nahi aata hai. He should get marks. This is the problem. And you have to convince them and make them understand. We'll come to that later. So take a history. How is this child's behavior in the uncle's house? Can he stay overnight with the Mausi's, what do you say, mother's sister? Can he stay with her overnight for 2 days or 1 day? This is very important to us. So, not just academics, understands and explain but seems unable to do it. Why did you jump from the top stairs and you broke your leg? You know how it learned? I know, mommy, but I could not resist. Fan is here. Why did you put your hand in the fan? You know how you will get hurt. I know, but when I saw the fan, I could not resist. I know, but I cannot resist. This is a very important history. So it's not that the child has an intellectual disability, he can't understand. He understands, but he can't resist the impulse to do it. That's the point. Get somewhat better, but as he gets older, gets little better, hyperactivity is better, but the story goes on, worsens from the home first to the neighborhood, school, college, job, everywhere this continues. This is a typical ADHD scene that we are talking about. So one is check for vision and hearing in all these children. Check for allergies, sleep, diet, family environment. Why? Why? We discuss this. Now, we discuss this. This is very important to rule out vision and hearing. And then, if in spite of all these being ruled out, you still have a problem, this is ADHD. Are you getting the point? Is this clear? So look at the entire slide. Hyperactive, not doing well in school. He has to have a loss. There is a problem with academics, with behavior, with peers. He has no delay. All of this on the left side, only then will think of ADHD. Counsel the parents about what we are going to talk to later. This child may be requiring a referral. Don't refer directly for some therapies because what therapy has to be done has to be first decided by a correct diagnosis. And that's why it's very important for all of us to keep monitoring the children, that are the children doing better with whatever you have asked them to do. Scenario 4. In 4, we have two different scenarios, but what is the title? Hyperactive, not doing well. He's not picking up. He's lagging behind. But this child has a history of speech delay. Are you getting my point? He has a history of speech delay. He hardly speaks anything. Doesn't speak anything at all. He does not follow commands. He has very good eye contact. But when you call out to his name from behind, he will not turn around and look at you. But he's excellent at using gestures and actions and pointing out everything. He can look at you, understand what you are doing. He can pick up your body language and gestures. What do you think? Before we come to hearing, hearing is a diagnosis. What is the approach? What is wrong with this child? So, expressive. So expressive speech is not there. Fine. What else? Is there only expressive speech? Since morning, I'm the only one expressing, but you are the nice guys. You are receiving. So you are the nice guy. So receptive speech, comprehension of speech. Does he have comprehension of speech?
Yes, I have opportunity.
Yes, poor receptive speech also. Question is, if you have poor receptive speech, can you have good expressive speech? If you cannot sit, can you walk? When you hear, when you understand what is being spoken, only then can you learn to speak, correct? So if there is no receptive speech, there is no question of expressive speech. So what is out is verbal communication. So what is the problem with this child? He has verbal communication. What is good in this child? Why are you saying that? Use of gestures and communication in gestures. So this child has good non-verbal communication, but poor verbal communication, receptive and expressive. So that's why you are right. In this case, what you will do is a hearing evaluation. The approach is important. Don't jump to a conclusion. The approach that a child has good non-verbal but poor verbal and poor all verbal, receptive as well as expressive. So of course you also check for vision, hearing aids, cochlear implant. This is a child after a cochlear implant or a hearing aid may require specific speech therapy, but we rush to send everybody to speech therapy. Don't do that. We discuss all the other children so far. We will discuss some more. But this is a specific case which requires this therapy. And counsel parents about education, etc. We won't go into that. Next case. Child has a hyperactive child running around in your clinic, not sitting in his place in the classroom, but he's not picking up, not doing well. And he has a history of speech delay as well. But it's 4B is different from 4A. How is 4B this child different? He speaks, but only nursery rhymes or numbers or names. Previous child, 4A. What was he speaking? Nothing. The previous child was speaking nothing. Remember this. This is how you will be masters of this topic. Previous child was not speaking anything. This child speaks. What? Please read this aloud. What? Only rhymes, numbers, alphabets. Okay. But he does not follow oral commands. He has poor eye contact and does not respond to name call and respected. Now, what is the approach? Don't tell me the diagnosis. You will be wrong. What is the approach? Clinical. What is wrong with this child? Because before that, what is wrong in this child? No, I understand. That could be the reasons. But what is the approach to this history? How will you organize the history in your mind? Next. What is wrong? He has poor verbal communication. Is this right? Do you think he has normal verbal expressive speech? No, he's only repeating. So it's very important to understand this is not normal expressive speech. Does he understand other speech? So what is out of the window? Receptive and expressive. Verbal communication is out. What is the next part of communication or earlier part we said? Non-verbal communication. And what is non-verbal communication? He does not have non-verbal communication at all. He has poor eye contact. So this child is a problem with both non-verbal as well as verbal communication. This is the difference between the previous child. The previous child had problem only verbal communication. This child has a problem in verbal and non-verbal. So in this case, again, check for a hearing. Every child developmental problem, check for vision and hearing. But you check for what we call, SRK sign. What is SRK sign? Oh, what is SRK? So what is Shahrukh sign? Can you stand up, please? Stand up and demonstrate. Yeah? Please stand up. Yes, sure. No, he doesn't sit and do that. Shahrukh doesn't sit. He's usually on top of a mountain when he does that. Please stand up. Come on, we are scored. When Shah Rukh Khan does this, what is the response? Whoever is the leading lady, she comes running to him for a hug. This is called good non-verbal interaction or communication. When the father puts out his hand, if not the mother, at least the child comes running to the father. This is in American medical jargon called excellent social reciprocity. It makes, here is what it is, you've got autism. Simple. When the father puts out his hand, the child reciprocates by understanding that my father wants a hug. He recognizes that and he responds, reciprocates by going to have ahead and giving him a hug. This understanding is very, very important in a normal child. Even after 7, 8, 9, 10, 11-month-old child, the mother puts out her hand, the child comes running. Have you seen that? This is normal development by 8, 9, 10 months of age. Social reciprocity. Responding to the non-verbal gesture of affection or love by another human. That's social reciprocity. This is a simple way of understanding just to make it funny. People don't remember DSM-5, but they always remember the short term sign. That's why I made it like that. So the child does not. When the mother is putting out her hand, when she's calling out to the child, when she's doing like this, when she's going out of the door, he's not bothered. He has no human reciprocity. The absence of that. If all this is there, then you will suspect autism spectrum disorder. So poor social interaction, poor non-verbal and poor verbal altogether, the child is not connected to humans at all. This is what you would call autism. So you need to counsel the parent. We'll come to that later. This is the child that needs to develop, refer to development. But what is your job after that? Very good. So the most important message today is monitor this child. Red flags, as you are all aware, no big smiles or joyful expressions for autism. No consistent response when child's name is called. Does not gesture, wave, point or show by 12 months. Does not say single meaningful words by 16 months. SRK sign, as I said, is absent. So going ahead, there is a, there are some lectures on DIAP. Somebody mentioned, Dr. mentioned. There's also a book of developmental behavior pediatrics. In that, I've written something extra, which is our own theory, which was mentioned earlier, which we call it Neural's theory of social interaction for autism. I won't take your time today, but you may see those the DIP lecture, or there is a new channel of Neural's Child Development Center. On that channel, we put these videos, which you can even share with the parents, so you don't have to waste much time. So going ahead now, this is a third case. Child has global development delay, hyperactive child, not learning well, but he has a global development delay. Now, what will you do with this child? This child needs a thorough medical and a neurological examination. So what will you examine for? Dysmorphology, skull, spine, skin, facial changes, limbs. Is this clear so far? This is a topic of your expertise, so I won't go much into it. Neurological deficits, tone, power, reflexes, you are sure about. Now, go back to this child with hyperactivity, with not learning well, not developing well, and he has global development delay. 5A is unable to keep up with his peers socially, at play, and at academics. It's not just school. Go back to the history at school, at home, at neighbor's place. Is he able to understand what other children are playing? Is he able to connect to them? Is he able to adapt to the situation? Does he know how to behave differently at one uncle's house who is a little strict as compared to another uncle who is very, very lenient? Are you getting my point? We know that, right? Yet Khadus uncle, we say, Khadus means a very cantankerous fellow. So I don't want to do something, but let me keep quiet till he goes away. Oh, this uncle is very sweet. I can even put my hand on his head and he will not say anything. So here I can do anything I want. This understanding is social adaptability. You are adjusting, the word that sir used, you are adjusting to a situation. This child cannot adjust. He cannot pick these things up. He does better with repeated instructions. So one time you tell children, all of you come here, sit down and play this. 5 other children will understand. This one child will not. You need to tell him again and again, one-on-one, repeatedly, but then he starts speaking. The previous child, the one with autism, even if you say repeatedly, he will not pick up. He will start repeating what you say, meaning this. This child is understanding. Nothing significant of so-called medical history, as if all the others was geography. That was also medical history, but pediatricians think no. Only what is seen on MRI, birth asphyxia, that is medical history. Everything that we discuss is social behavioral history, is all medical history. But in this case, let's look at what we can do. Scenario 5B, another child, exactly like the one on the left. In addition, look at what he has. He has an eventful perinatal history. He has a history of seizure. He has dysmorphic features. So can you see? Hyperactive, not doing well, global development delay. This is what the one child has, but no medical history so far. This child also has an eventful perinatal history. Are you able to compare the two children in your mind when they come to your OPD? Are you okay? Alright, now what do we do for both? 5A, we said all this, unable to keep up with his peers, nothing significant on medical history. It's very important to go again for the same thing. Vision and hearing. He has poor adaptive skills, suspect global developmental delay and intellectual disability. This is a typical child. He may not have a history of birth asphyxia. He may not have dysmorphology, but he is slow to pick up everywhere. He is slow to adapt and he is slow at academics. So counsel parents and set goals. Work one-on-one. This child can only do well if he gets one-on-one attention everywhere. This child needs that one-on-one attention. And if the parents are looking for the next pregnancy, they require a generic diagnosis. Otherwise, you don't need to make him do a whole exome sequence and spend 25,000 rupees on that, another 10,000 in MRI. You don't need it. Is this clear? Is this clear? So this is a typical example of a child we had at New Horizons. He was referred to multiple pediatricians, multiple doctors, multiple therapists, multiple special educators. Everywhere just kept getting some therapy or the other. Basically, as you can see, typical child, history of bad obstetric history in the mother, some other cousins in the family. This turned out to be a child with Fragile X syndrome. Is this clear? So he is at 5A. There was no specific. Remember one thing about dysmorphology in Fragile X. The typical features are evident only after 8, 9, 10 years of age. They are not evident. A 4-year-old child, you can't pick up on dysmorphology with Fragile X. Is the message clear? Everybody awake, sir? Okay. Going on ahead. Scenario 5B, where we said he had eventful perinatal history, seizures, dysmorphology. This child is the typical neurological case that we talk about. He will require an EEG, he will require neuroimaging, genetic evaluation, he will require medications, perhaps for the epilepsy. This is the child you need to work on. All the other children, you don't need to do an MRI, you don't need to do any EEG. Is the message clear? Okay, so going ahead now. Child has no global developmental delay. This is the last case. Here again, if you see, no significant birth history, no developmental delay, no dysmorphology. Examination normal, but confusion with right and left side, above and below. Confusion with spoken language. Instead of ask, child may say ask. Instead of left, he may say right. Right slipper in the left foot. These things are common. Difficulty learning alphabet sounds. Confusion between B and D, P and Q. Are you getting the point now? But look at the left side. This and that. So you have to be able to put this all together and see patterns of errors in reading, writing, and arithmetic. First, leave this point out. Only with this, you should be able to make out that he has no developmental delay, he has no speech problem, he has no autism, he has no ADHD, he has no intellectual disability, because this thing tells you he has a problem only with specific learning, and hence this is a child with specific learning disability. So again, what you will do is no investigations needed. This is a child who requires evaluations for specific learning disability, and this is a program for academic what Dr. Surprakasha has been doing all his life and life. Only this child. Have you been able to understand clinically how you pick up these children? So going ahead, finally, what will we do about hyperactivity? Take a simple history, right from pregnancy, perinatal history, developmental milestones, early childhood development, and in school, don't focus on academics. School also first focus on behavior. This is the message for today's talk. Don't only focus on academics. First focus on behavior, then on communication, then academic. Explore each symptom in such detail. Don't jump to a label. If it is hyperactivity, explore the hyperactivity. There is a speech delay, explore the speech delay. Is it only expressive speech? Is it receptive and expressive? Is it non-verbal delay also? This is how we go about it. And in combination, you can come to a diagnosis without needing some great test or MRI. Examination, all of you are experts in all of this. I don't need to say. Investigations, point was only if indicated. But I can't tell you the number of children with autism who go around getting an MRI, whole exome sequence, EEG, always largely normal. But the parents end up spending just 50,000 rupees just in this set of investigations. Not needed. I hope you understood which set of children need an investigations. Many of us have done the IAP program on early childhood development, and this is what important. You have to talk to the parent about nutrition. So the details are the same. Nutrition, responsive parenting, screen time has to be stopped, developmental screening, safety and security. This was all done in the IAP ECD module, so I won't go into detail. But all of you are experts at this. The point is diagnose correctly and counsel the parents based on this. Now, if required, refer to a developmental pediatrician. But if the developmental pediatrician also writes on the piece of paper the same history and says refer to XYZ therapist and ABC therapy, doubt it. Which means even the developmental pediatrician has no specific diagnosis, then how is it different from what you did? So reference is not the only thing of doing developmental pediatrics. Understanding the development of the child and being able to deal with it with the family and the community in the Indian setting is more important. It's not only about refer to XYZ and refer to ABC. And if somebody is doing that, then you also need to be aware that they have also not gone through the entire approach that we spoke today. So take home messages are do not be in a hurry to label, especially the symptoms. Child is hyperactive. Don't call it ADHD. Speech delay, learning difficulty, not doing well, slow learner, they're all terms being used in schools. Don't be in a hurry. Don't mistake symptoms for the disorder. Differentiate between the symptoms and the disorder. I'm sure we did that today. Analyze the symptoms, map the like cough, cold, fever will be respiratory tract. Vomiting, loose motions, fever will be gastrointestinal tract. At least start doing that. It's quite easy to do it. Do not initiate symptom-based therapy. Child has a speech problem, refer to XYZ. Child has a behavioral problem, refer to ABC. Child has a, don't do that. It's just like if a child has fever, you give Procin. But if the child has fever for 15 days, will you keep giving paracetamol? The child has fever cough for 15 days, you keep giving cough syrups only. You will have to come to a diagnosis. So keep that in mind. This is the book that I told you about. It's available on JP or on your online. This is acknowledgement to the Indian Academy of Pediatrics, our chapter. This was a wonderful team 5 years back with Foundation Day photograph. We are now 21 years. And thanks to again our team for all this that I told you together. Nothing of this is a textbook knowledge. All of it is practice. The whole idea here is to request all of you to think that you are developmental pediatricians. It is not difficult at all. If all of you can diagnose malignancy and complicated tuberculosis and malaria, this is far more easier, isn't it? I can't hear you. Yes. Isn't it easier than dealing with a complicated tuberculosis? So just requires you to give a right approach and a little bit of time and follow the child. So with this, I'd like to thank the chairperson, all of you, and we'd like to thank you very much.
Thanks, sir, for the inaugurative and informative speech, and it should be displayed in YouTube so that it can be heard by all over in Tamil Nadu, so that everybody will change and diagnose all the conditions without any difficulty. It's a simple algorithm here given, and thank you so much, sir, for the clear-cut idea. The discussion will be at the last.
Thank you, sir. Thank you, sir, for the wonderful lecture. And I request Dr. Sivaprakasan to felicitate our speaker, Dr. Sami. First, IMD President Pondicherry, Dr. Ravichandran, to felicitate our moderator, Dr. Sivaprakasan. Next program, a talk on horses, mules, and zebras Common, Uncommon, but Important, Rare by Dr. Tushar Manya, our moderator, Dr. Soundarajan P.
That is this one next.
Mhm.
The next, then the back one. Hello. Check. Evenings. Yeah, please put down. Morning.
I'm Dr. Souther. I thank the organizers for giving the opportunity. But the audience also might be surprised about the titles or the names and the. In fact, I was also surprised. In fact, I called sir, what is it about what I'm going to talk about? I mean, and he said, no, it is only going to be interesting, interactive case scenarios, which we never, miss the common thing. And but at the same time, not ignoring the uncommon and the rare things. In fact, those days, general medicine they used to say, they think of always a uncommon presentation of a common illness rather than thinking of a common presentation of an uncommon illness. That was. Sir is the director, Pune Clinic, MD Mumbai, and he has contributed for wisdom resolutions. In fact, apart from that, I was searching for that name. He has put a lot of OSCE materials in OSCE. Right. It could have been useful to so many DMP candidates actually.
Thank you.
But I learned yesterday from. Thank you, sir. I mean, the floor is yours.
Thank you so much. Can you see this?
How many of you thought that IAP is starting a new chapter in pediatric veterinary medicine after this talk? Okay, a lot of people look at me suspiciously. Then my only excuse is many of my patients also don't speak, just like the pets and the veterinary doctors. Most of the time, the caretaker speaks. But don't worry, we are not discussing any of that. Before I start my talk, let me tell you what I associate Pondicherry with and what I have learned from Pondicherry all along. We all have excuses in our life, and there are few people who have led by examples against these excuses. One of them, you know him probably better than me, is Dr. Srinivasan sir. Age is not an excuse for anybody as far as learning and teaching is concerned. Just for your information, he is currently in US and he is listening to us on Zoom. He was waiting for last 2 hours and staying awake in the middle of the night. He's even sent a message to me, and I'm going to quote, saying Thiru has done so much work. Sorry, I'm saying Thiru because I'm quoting him. Has so much work to get this hall and this Pedicon moving. So give him a big hand for that. Thank you. The other common excuse is what Dr. Srinivasan sir said for you. Don't worry, it was all good. So we always worry about and have excuse saying, I don't want to do this because I don't have resources. I don't want to keep patient records. I don't want to follow rational pediatric
வாய்ஸ் கேட்கலாமா? வாய்ஸே கேட்கலப்பா. என் வாய்ஸ் கேக்குதா? அவர் பேசுறதெல்லாம் மௌன இது மாதிரி படம் மாதிரி இருந்தது. கொஞ்சம் சரி பண்றியா? வாய்ஸே கேட்கலப்பா, அவர் வாய்ஸே. அது முதல்ல இது சமீர் நல்லா கேட்டது. ஆமா, மௌன படம் பார்க்குற மாதிரி இருந்தது. அஃப்கோர்ஸ் ஐ லிசன் டு திஸ் டாக் ஏர்லியர் இன் தி. நாங்க பேசுறது உனக்கு கேட்குறதா? ஐஏபி டிஎன்எஸ்சி வந்து மியூட்டா இருக்கு. ஐஏபி டிஎன்எஸ்சிங்கிறது மியூட்டா இருக்கு. இந்த ஐஏபி டிஎன்எஸ்சிங்கிறதுல வந்து மியூட்டா இருக்கு. என்னன்னு தெரியல. நல்லா கேட்டுட்டு இருந்தது. அவர் வந்து முதல்ல ஆரம்பிச்ச போது கேட்டது. அதுக்கப்புறம் கேட்கல. ஹலோ ஜனனி. சவுண்டு கேட்டாதான் இல்லாட்டா ஜனனி வாய்ஸ் இப்பதான் பார்க்க முடியும். நல்லா போயிட்டு இருந்ததுப்பா, திடீர்னு இந்த மாதிரி ஆயிடுச்சு. You can hear me? You are able to hear me? அது உங்க ஐஏபிடின்னு சில இது பிளாக் ஆயிருக்கு இந்த சவுண்டு. முதல் டாக் நல்லா கேட்டது. செகண்ட் டாக் முதல்ல ஆரம்பிச்ச போது கேட்டது, அதுக்கப்புறம் கேட்கல. இந்த உங்க சைடுல ஐஏபி டிஎன்எஸ்ங்கிறது மைக் ஆஃப் ஆயிருக்கு. காதுல விழல. ஐஏபி டிஎன்எஸ்சி பிளாக் ஆயிருக்குப்பா. முதல்ல நல்லா வந்து சமீர் பேசும்பொழுது, அதுக்கப்புறம் ஆரேஷன் கேட்க முடியாதுன்னு நினைக்கிறேன். இனியா சார் வந்துட்டாரு, சரி பண்ணிடுவார். அந்த ஐஏபி டிஎன்எஸ்சின்னு உங்க இது வந்து ரெட்ல இருக்கு, மியூட்டடா இருக்கு. சைடில் ஐஏபி டிஎன்எஸ்சியில் மியூட்டா இருக்கு. இதில் மியூட்டா இருக்கு. மகாதேவனா?
Created by Dr. Tirumurugan Sera from his Convich neonatal class.
I can hear now.
Acknowledge noble guest for the promotion of academics. And now we are asked, and now we will announce the winner, Madam Janani Shankar, who is the winner of the NSVMC audit. Madam is Director of Kanji Kamakodi Child Trust Hospital, Chennai. And I am very happy to say that I was the college mate of Janani Madam. Madam completed her MBBS from Madras Medical College, and she completed her DPNB in the year 1995. She has obtained her PhD degree from the Dr. MGR Medical University. She is very, very academically oriented. She has published 60 papers in national and international journals. She is Central IAP member and also on the editorial board of IJPP. She has won numerous awards. To mention a few, Dr. Balagopal Raju Award, Dr. C.T. Tirunjana Sambandam Award, Dr. T. Rajagopal Award, Dr. K.A. Krishnamurthy Award. Madam is also on the committee of WHO on dengue. She is also committee member of the Tuberculosis in Children Management Committee. With these few words, I request Madam to come over and receive the award.
Congratulations, Janani.
Dr. Ravichandra will be the moderator for the session.
Thank you. Good afternoon, everyone gathered here. I'm really honored to get the award in the name of my teachers, Dr. Nalini, Dr. Srinivasan, Dr. Mahadevan, Dr. Vishnu Bhatt, and Dr. Chidambaram. I think I know them all from the time I started my pediatric career, more than almost 30 years now. So without wasting much time, I'll just take you through the oration. So the flow of my presentation is, I think, our great teachers or our next to our teachers, I think the teachers that are there every day with us is our patients. Our patients are our teachers. So I'm just going to title my presentation as Lessons Learned from Patients. Every day we learn. I think patients as well as our students are our teachers. So they ask us questions and make us read more. So I'll just take you through the flow of my presentation is, I'll just share a few scenarios from where history helps us in diagnosis, then the clinical clues, where the cultures were of help, and imaging, histopathology, and finally genetics. So history. So I'll just take you through the scenarios. All of them were my own patients. So this is Master X. How do I change? The change button.
This one.
Next. So Master S, a 5-year-old developmentally normal child, came to us with a history of limb pains. I'm presenting 3 children with limb pains. If you look at the bold letters, the child woke up from sleep crying in pain. And pain was present all through the lower limb, not localizing to any joint or muscle. So this is his history. He was very well otherwise. There was history of undocumented fever 2 weeks prior to the illness. He was wincing in pain. When we looked at him in the ER, he was wincing in pain. He was not allowing us to touch him. There was, of course, no localized swelling. So these were his labs, leukopenia and platelets were normal. Hemoglobin also was well preserved. Just because he had such severe limb pains, we just went ahead and did the peripheral smear, which showed 4% atypical cells, and bone marrow was suggestive of B-cell ALL. Scenario 2, again, Master X, 2-year-old, normal earlier, leg pain since 1 month, gradually stopped mobilizing and preferred to be carried or preferred to lie down. Even to the restroom, he was carried. He was admitted outside. This was during the COVID times. So he was treated as post-COVID arthralgia with steroids. Again, in view of persistent symptoms, he was admitted elsewhere and he was labeled as juvenile idiopathic arthritis. Also started on oral methotrexate. So when he came to us, when there was no improvement, when he came to us, he was having gross pallor, no organomegaly. He was keeping the legs flexed with severe tenderness on palpation. So these were his labs, nothing, no clues from the lab except for a high ESR and a high CRP, which was suggestive of some inflammation that was going on. So again, peripheral smear was normal. Ultrasound was done outside, that was normal. But here at KKCTH, when we did the ultrasound, there was a mass in the upper abdomen measuring 7 into 4 centimeters. And we went ahead and did a bone marrow, 22% of atypical cells, PET CT primary neuroblastoma. And he was CD81 and 56 positive, consistent with neuroblastoma. Third scenario, the same with limb pains, 13-year-old, previously well, developmentally normal. Complained of pain in multiple joints in both the lower limbs, intermittent for 2 months, involved the ankle joint and the metatarsophalangeal joints, but she didn't have anything else. She had some low skin rashes, which was noticed in the lower limb. She was managed as growing pains. Very uncommon. Adolescent girl being labeled as growing pain is not really correct. So when she came to us, we looked for all, how Tushar mentioned, a girl child comes with fever, we always think of SLE. So she had skin rashes, she had oral ulcers, she had hair fall, she had loss of weight. So all these were leading questions which we asked. And she was referred as suspected HSP-related arthritis, and she turned out to be SLE. So she satisfied the SLIC criteria. The CRP ESR discordance was there. So she was DCT positive, ANA positive, anti-DSDNA positive. So she was SLE. So I just wanted to tell you the diagnostic. In growing pains, you should never label them as growing pains. It's better to overdo than underdo. Always ask for a peripheral smear study apart from your vitamin D levels, because parents keep coming to you with growing pains. Whenever the child gets woken up from sleep in the night, or the child doesn't allow you to touch the limbs, please beware of something else that's going on, and never start on steroids without getting a diagnosis. Never start on steroids or immunosuppressants without doing a bone marrow. That's the message. So the lessons learned for this: watch out for red flags, nocturnal pains, you have to beware, and basic investigations. Peripheral smear study is always important. CBC may not give you a clue. This is again another scenario where the history helped. He was a 2-year-old boy, fever of 1.5 months, skin rash he had for 1 month. He had generalized lymphadenopathy, generalized erythema, and mild hepatosplenomegaly. We were just wondering what we were dealing with. Too young to have a JIA. All the baseline workup were negative except for the OTPT, which was mildly elevated. Bone marrow, everything we did, we were not getting any clues. Then we got the history of being started on phenobarbital and valproate at the native place for complex febrile seizures. It was stress. So skin biopsy confirmed the diagnosis. So in any child with FEO presenting with fever, rash, lymphadenopathy with visceral involvement, drug hypersensitivity should be considered. Eosinophilia may be absent. Don't think that just because eosinophilia is not there, we should not label it as stress. Initial stages, eosinophilia may be absent in about 10 to 50%. So that's again a message. History of drugs is very, very important when you have something like this, a systemic illness. So moving on to clinical clues from history. So, of course, Eshkar, I think all of you are very experts in finding out Eshkars from hidden areas. So, any child comes to you with fever, which is going on, and with some edema, some hepatomegaly, and some eyelid edema, always just expose the child and look for Eshkar in hidden areas. Peticulae, of course, recovering dengue, a subconjunctival bleed in a child with an ITP, palmar plantar erythema. This is again a very interesting child. She came to during the COVID times with gross pallor, and she was a Muslim child wearing a hijab. I just removed her hijab to look for lymph nodes, and I found this live lice moving in her head. So COVID time, she did not want to have a bath. She did not want to comb her hair. She was glued to the bed all the time. And the parents, they were very educated and they were very embarrassed when we said that is the reason for the pallor. Her hemoglobin was only about 3. So we didn't do any investigations. We just told them to tonsure her hair, apply Perlize, and started her on iron supplements. We didn't even admit her. Hyperpigmentation, again, a child with developmental delay, like what Samir mentioned. This is one clinical clue that helps you. Hyperpigmentation knuckles, think of megaloblastic anemia. So other clinical clues, this again is a very interesting child. This child, I think Dr. Namashivayam will remember. She's from Kadalur. Remember Marcelin, sir? Marcelin? Yes. So this girl, I think about maybe 20 years back, she was referred by, I think sir only referred. She was came with a fever, bulging fontanel, irritability. Clinical diagnosis, just by looking at her, you can say that it's meningitis. CSF was also suggestive of meningitis. She was not improving with ceftriaxone and vancomycin. And she developed hydrocephalus, needed an external ventricular drainage. This is the MRI. And when we got the report, CSF culture, E. coli, ESBL producing. In fact, I called the lab and asked them whether they mistook a urine sample and reported, because CSF, ESBL, E. coli is unheard of. Then we went ahead and stripped and examined her. She had a dermal sinus, which was having a neurological extension. So MRI spine showed dermal sinus tract, which with intracranial extension, which was excised. She's doing well on follow-up. She has about, some sequelae, but she's doing otherwise well. So this is her after recovery. So the lessons learned: meningitis in a child with dermal sinus, gram-negative and staph can cause meningitis. Image and refer to neurosurgeon whenever you have a dimple or punctum over the lumbar spine, above the intergluteal creases. That's very important. Anything found above the intergluteal creases, midline, subcutaneous fluid fills, cyst, circumscribed atrophic skin, a tuft of hair, please refer to the neurosurgeon. MRI spine is essential, because otherwise at a later stage, this child can present with meningitis. So this is another child who was again referred from, if I remember, it was from Karaikal, was diagnosed as dilated cardiomyopathy and started on anti-failure measures. And at admission here in our hospital, because the child was not improving with anti-failure measures for almost 3 months, parents brought them to our hospital. When we examined her, the BP was 170 by 120. The parents said the BP was not measured in the other hospital for the last 3 months. Not even once the BP was measured. Because we were using the manual BP cuff, different cuffs we were tying. I think Dr. Namalwar was a nephrologist at that time. He used to personally tie the cuff and measure the blood pressure. So they were very stunned when so many people were trying to measure the blood pressure. They said this was not done at the other hospital. So when we did the investigation, she had gross cardiomegaly. RFT was normal. She had features of LVH and very low ejection fraction. She had a ovoid mass, upper pole of left kidney. CT abdomen confirmed the same, had some calcifications. So she was a secondary hypertension because of the mass. So she was a very difficult to control hypertension. She needed multiple antihypertensives. Once the blood pressure was under control, a laparotomy was done. So laparotomy done and total excision of mass was done. So importance of routine blood pressure check in pediatric practice. Don't ignore that. It's a very simple, non-invasive thing that's available at your bedside. Don't never ignore. So I think in a busy OP, of course, you can use it selectively for children who have some problems. But if you're free and your OP is not very busy, I think every child should need a blood pressure check. So moving on from clinical clues to cultures, I think you should have an excellent microbiology lab support without which you cannot diagnose most of it. Tropical fevers are on the rise. And this is a 7-year-old boy, had arthralgia left ankle, had a mild hepatosplenomegaly. So these were our differentials. Everything was negative, clueless, bone marrow. Always any prolonged fever, PUO, bone marrow cultures are a very, very useful tool for getting the diagnosis. Whatever you miss in the blood culture, you can make out in the bone marrow. So bone marrow reactive marrow, bone marrow culture grew Brucella melitensis. So treatable again, very history of ingestion of unpasteurized milk was there when we asked the history. So again, another scenario, 9-year-old boy, fever of 3 weeks, abdominal distension of 1 week, and had some breathing difficulty, had moderate hepatosplenomegaly and generalized lymphadenopathy. Ultrasound showed hypoechoic lesions in the liver and spleen. Otherwise, he had just a mild transaminitis and a high total count with a normal reactive marrow. Again, fever, lymphadenopathy, hepatosplenomegaly, pneumonia with microabscess in liver and spleen. We always think of tuberculosis. There is no evidence of malignancy. Burkholderia pseudomallei, bone marrow culture. So melioidosis, again, do not miss it. We had one more girl where the brain biopsy was done and brain biopsy specimen grew melioidosis. She was a neuromelioidosis. So lessons learned, zoonotic infections and other rare infections like melioidosis are important causes of FUO. And bone marrow culture, always do not hesitate to send a bone marrow culture. Whenever you do a bone marrow smear study, also send a culture if the child has an FUO. Moving on to importance of imaging. So this is a 3-month-old infant whom I treated. 3rd-degree consanguineous parents, exclusively breastfed, uneven full antenatal neonatal period, immunized. Came to us first for loose stools of 1 month duration, fever, cough, fast breathing, poor feeding. He was encephalopathic when we admitted him. He was encephalopathic with seizure, tachypneic hepatomegaly. No reaction at the BCG site. He was had to be intubated and shifted to PICU. So initial investigations, there was leukopenia. If you look carefully at the differential, there is lymphopenia. For an infant, a lymphocyte count of 20% is something that is to be noted. He had a dyselectrolytemia and transaminitis. CSF was abnormal. And he had absent thymic shadow. So that was again a skid who has been, a transplant has been done. And he's doing well post-transplant. He had some CMV retinitis, but with valaciclovir and other drugs, he's doing really well. So the importance of looking at the thymic shadow in the X-ray and looking at lymphopenia in an infant, always do not forget to PID, especially SCID. 45 days old female infant referred from Salem as a possible case of AML. She was otherwise well. She had splenohepatomegaly with gross pallor. So this few petechiae in the lower limbs, gross pallor, huge liver and spleen. So she had, this was the picture which made them think of AML. This is typical leukoerythroblastic picture which you get in osteopetrosis. So we did X-ray and we found dense bones. We were actually preparing to do a bone marrow, but I just said that why don't we do an X-ray? So when we did the chest X-ray, it was like dense bones and we confirmed it with long bone X-rays. So in a child with pallor, hepatosplenomegaly, bleeds, one of your differential diagnoses should be osteopetrosis. Do not forget that. So because it was an infant with osteopetrosis, it's a malignant type. This is again a 1 year, 9-month-old female child. This is a very interesting child. She was having loose stools for almost 3 months. So she was treated as protracted diarrhea with different kinds of probiotics and different kinds of antibiotics. And she came to us with a potassium of 1.6. Severe hypokalemia, signs of some dehydration, very undernourished, looking sick. Ultrasound just had dilated bowel loops. These were serial potassium and bicarbonate. Persisting loose stools, documented weight loss, and persisting dyselectrolytemia. So we went ahead and did everything that is possible under the sun for a child with protracted diarrhea. Everything was normal. So we looked into the etiology of chronic diarrhea. Nelson, one thing I want to tell the postgraduates, Nelson, those tabular columns are so useful. Whenever you have a problem, just go back to Nelson. This is a tabular column from Nelson. He gives you all these things, and he also mentions neoplastic diseases, which we never thought of. So we relooked and we thought, okay, that is the only thing that we have not ruled out. So we went ahead and did a PET CT, well-defined metabolically active soft tissue density lesion. So this was a huge lesion. CT also confirmed the same. So bone marrow was normal, huge tumor. She was a ganglioneuroblastoma. Risk stratification, MMIC was not amplified, so she did not require any chemotherapy. It was totally removed. Diarrhea settled, hypokalemia and acidosis improved, and documented brain bleeding. So ganglioneuroblastoma, Kerner-Morrison syndrome. I mean, not that I'm saying all diarrheas, don't think of that, but when you have a child with 3 months diarrhea with dyselectrolytemia and loss of weight, don't forget this. Again, another case where scan helped us. 10 months old, previously well, developmentally normal female child, treated elsewhere and found to have anemia, leukocytosis, and elevated CRP. She was otherwise okay. She had a left retrocardiac consolidation, and so we had to admit her and treat her. Total leukocyte count was very high. Hemoglobin was low. And she was lost for follow-up. When we started her on iron, treated the retrocardiac consolidation with antibiotics, and put her on iron supplements. They never came back for 2-3 months. And 3 months later, when she developed these new lesions on the scalp, the parents got worried and they brought her. And she was still continued to have persistent anemia. So we were wondering what are we dealing with? Ultrasound, when we did, they said some infiltrates in the spleen and the liver. So we were very much sure that we are dealing with LCH because she's failing to thrive. She has anemia and she has lesions on the scalp and she has some infiltrates in the liver and spleen. So in fact, we were ordered for a PET scan for doing the staging before starting the treatment for LCH. We're very much sure. We did a biopsy of the scalp lesions. And we looked at the skeletal screening, did not show any lytic lesions. We were, worried that, why is not showing any lytic lesions correspondingly, we were wondering. So we ordered a whole body PET CT for staging. And the radiologist called and said this is tuberculosis and not LCH. Then retrospectively, we went and did the gene expert, the fasting gastric aspirate for AFB and gene expert, and it was positive. And she was started on ATT and she's doing really well. So if you look at the timeline of events, first admitted as community-acquired pneumonia, anemia, follow-up persistent anemia, leukocytosis, iron dosage was increased, then developed acneiform lesions, admitted for further evaluation. We were damn sure that it was LCH and it turned out to be tuberculosis. Again, it's a horse and not a zebra. So there are some reports, lichen scrofulosum, it's a very common presentation of tuberculosis. Again, a very interesting child. I don't know, I've not seen such a condition in my last 30 years. 3 years, maybe the older people in this audience would have seen such a kind of case. 3 or 4 months old male from Orissa, previously well, developmentally normal, leg pain for more than 1 month. So initially he complained of pain while walking, but later he stopped walking. Preferred to keep both his legs flexed at hips and knees even during sleep. Cried a lot when someone tried to extend his legs. Mild swelling of the right shin noticed by the family. No red flags at all. And they had consulted everyone and all the labs were normal except that the MRI showed some bone marrow edema. So analgesics, it turned out to be scurvy. Finally, so the MRI from the radiologist again called and said, is it scurvy? Bone marrow edema is there. So we started, vitamin C levels were low and we started him on vitamin C and he definitely improved. And so bone marrow edema and the metaphyseal end. Even the orthopedic surgeon as well as the radiologist, both of them, the scan center radiologist, both of them immediately said this is scurvy, which we have never seen. How many of you have seen scurvy, the youngsters at least? One case, Tushar has seen one. I think Madam Nalini, Madam Chidambaram, Madam and all would have seen, Mahadevan sir and all would have seen many more. I think this is the first case of scurvy that I have seen. So he's doing well. He started sitting and playing in 10 days, in 2 weeks standing and walking a few steps, and 4 weeks normal walking and running. So rare case of bone marrow edema. So again, scurvy mimicking spondyloarthropathy with bone marrow edema. A lot of case reports are there. Vitamin C deficiency mimicking inflammatory bone disease of the hand. Autistic child, early disease on MRI. Bone marrow is, the MRI of the bone is diagnostic. So scurvy, a forgotten cause of limb pain, re-emerging disease and no longer a historical disease. though rare in a developmentally normal child, can happen in children with poor abnormal dietary habits. MRI changes in scurvy, we need to get familiar as X-ray can be unremarkable in early stages. Scurvy mimics infectious, rheumatological, hematological, oncological causes, and high index of clinical suspicion is needed to avoid extensive investigations. So this is a child, also had bleeds, if you look at the gum bleeds. So see the posture, typical frog-like posture. And moving on to from imaging to histopathology, again, the lab always helps us in diagnosing so many cases of tuberculosis, so many cases of Kikuchi and others, we get it from the lab. So this is a 13-year-old previously well-adolescent girl. She's from Pondicherry, actually. So I'm good I have a case from Pondicherry. She's an adolescent girl who was doing +2, high-grade intermittent fever with excessive sweating. You won't believe every time she has a fever with the chills, she will actually rise from the bed and then come back on the bed. Because when the parents described, we were not believing it, but we saw it with our own eyes. She'll get lifted from the bed at least a few and then she'll come back to the bed, such severe rigors and chills, and the entire bed would be wet after we have to change the sheet. So much of sweat she used to have. So she was had pallor, abdominal, there was no other red flags and no history of contact with tuberculosis. She was thinly built, weighing 40 kgs. Otherwise, she had a few enlarged mobile, non-tender bilateral cervical nodes. These were her labs, nothing, not much of great clue except for the ESR, which was 70. She had a manto of 20 millimeters and numerous enlarged mesenteric porta hepatis and bilateral ilium group of nodes. And you also can see a hilar node in the chest X-ray. So she was, RGJ was negative. So we went ahead and did laparoscopic lymph node biopsy. Again, a message here, do not label and start them on ATT. Lymphoma can closely mimic tuberculosis. When you don't have a tissue diagnosis, I don't think, unless you rule out other things, you cannot label them as clinically diagnosed and start on ATT. So here we got the surgeon's help and got a laparoscopic lymph node biopsy. Lymph node expert MTB was positive and lymph node HPE was caseating granuloma. In fact, the surgeon called from the theater and said, this is, before going to the theater, the surgeon, we had a bet with the surgeon. She said, this is definitely lymphoma. I said, it's definitely tuberculosis. Then from the theater, she called and said, you're right, it's caseating granuloma. When they cut section was so much of caseation. She was started on category 1 ATT and fever settled and she's doing really well. So chronic infections like tuberculosis can present as FUO, and TB and lymphoma can mimic each other. Do not start on empirical ATT until you had obtained a tissue diagnosis. This is again a 3-year-old girl from Kadalur, intermittent fever of 1 month with weight loss, reduced activity, pain in the back of neck and shoulder, no swelling, but had painful restriction of neck movements. Was seen by an orthopedic surgeon. Cervical collar was applied and ATT was initiated as there were lesions in the cervical vertebra. There was no improvement after 1.5 months of ATT. Induction period, we waited for 1.5 months. There was absolutely no improvement. She still had a lot of neck pain. Tuberculosis alone, if you start all these bone and joint tuberculosis on ATT, you can see a remarkable improvement within a few weeks after starting. But this girl, she did not have any improvement. Manto was negative. Quantiferon was done by the orthopedic people, that was negative. ESR was 121. An MRI spine showed multiple lytic lesions involving the transverse process vertebral body. She had one lytic lesion in the scapula, which was biopsy could be done. It was an eosinophilic granuloma, and she improved with specific treatment. So this girl is doing very well. She's off the cervical collar, and again lytic lesions. We saw one case where LCH we thought, and it turned out to be tuberculosis. Here we thought tuberculosis, and it turned out to be eosinophilic granuloma. So finally, after all that history, clinical clues, and then imaging, and then histopathology, I think genetics is something that governs us. And as Sameer says, do not order whole exome and sequencing for every child with some diagnosis. I think that's become a very, impulsive. Everyone has become impulsive in writing that. Please do not do that. Very rarely when we have situations in clinical, practice, when we don't have a diagnosis, don't strike, and the child is not doing well, genetics helps. This is one such case. So he was a very interesting 4.5 months old male infant. who was otherwise well, came with multiple petechiae ecchymotic spots over the body and passing blood in stools. There was history of prolonged bleeding from the ears during his traditional ear boring ceremony. So no history of any other bleeds, no seizures, umbilical cord fell on time, and then no bleeding disorders in the family, no previous hospitalization. He was well nourished, no dysmorphism, had gross pallor, multiple petechiae and ecchymotic lesions over the face, trunk, and extremities. Also had a mild hepatosplenomegaly. So hemoglobin was 6.2, retic was 8%, DCT was positive, ANA was negative, ESR was 155. So there was thrombocytopenia with no evidence of hemolysis and normal sized platelets. Always when you have a child with thrombocytopenia, ask for the size of the platelets or look at the mean platelet volume in the culture report that is collected from the lab. That's very, very important clue that you have to know whether it is ITP or something else like inherited thrombocytopenias. So bone marrow study was also normal. So we labeled him as Evans syndrome because he had anemia and thrombocytopenia. We went ahead and did all the other second line workup. Everything was normal. So we labeled him as Evans syndrome, started him on specific treatment. He did not improve at all. We added steroid, we adjusted the dosage, we added mycophenolate mofetil. He didn't improve. He continued to have anemia, and thrombocytopenia was one thing that was not improving at all, was concerning us. So persisting bicytopenia, BCT became negative. Repeat bone marrow, again, we said again normal. Again, it was normal. Steroid and MMF was continued. And recurrent infections, he also developed recurrent infections. He had ecthyma gangrenosum during the course of illness, once Pseudomonas, and he had hand-foot-mouth disease once, and then enterocolitis the other time. So when we put all these things together, are we missing a primary immune deficiency? What is happening? So we did the clinical exome sequencing, and it turned out to be Wiskott-Aldrich syndrome. Again, a message here is a male child coming to you with thrombocytopenia at a very early age. Do not forget Wiskott-Aldrich. Keep it at least down in the line in your differential diagnosis, because that's something you should never miss. We have so many chronic ITPs, no? We just keep labeling them as chronic ITP. They do well, they come in between, we put them on pulse dexamethasone. But definitely, they're not improving and they're also developing some infections in between. Definitely don't forget about no eczema, normal size platelets. That was one thing that was. So, I don't know why this guy always had a normal size platelet. That was one thing that deviated us from Wiskott-Aldrich in the beginning. We did a Sanger sequencing of parents. Same variant VAS mutation was detected in the mother. So this child actually, a bone marrow transplant was planned. And just before the pre-induction for bone marrow, we lost him because of a massive intracranial bleed. The mother had an antenatal diagnosis for the second child, and then the second child is normal and healthy and about a year old now. Just they celebrated the first birthday last week. So Wiskott-Aldrich syndrome. So autoimmunity can be presenting manifestation of Wiskott-Aldrich syndrome. Child with VAS can have normal size platelets, and the age of onset of eczema is variable. Don't think that the classic triad described in the book should be there to diagnose VAS. VAS should be suspected in any male child with unexplained thrombocytopenia or autoimmunity along with recurrent infections. I think I'll conclude my talk with that. So again, I think back to basics, history only helped. The maximum scenarios I had only in history and clinical, and then the labs, and then the imaging, and then finally only one case in genetics. So I think history and physical examination are the key in practice, and PGs don't forget to get a good history and lend your ears, listen to the parents, and strip the child and examine. I thank the organizers in Pondicherry Academy of Pediatrics. I thank all the teachers in whose name the award has been instituted. And I thank my family who's here, my husband, who's been tolerating me for the last 38 years. So without him, I think I wouldn't be standing here and doing this oration. That's my husband there. Yeah.
We request the family to come out for a photo.
And my mother, who's a single parent who brought me up and brought us up and gave this education to me. And my mother-in-law, I think more than my mother. I got married when I was in third year medical college. Just 20 years old when I got married, and she was the one who motivated me, encouraged me. And of course, I miss my father-in-law here. He was a great motivating support for me. I miss him. But my mother-in-law is here. Thank you all, and yeah. Just,
Will you call madam? I will congratulate her.
Let's Dr. Govindan to felicitate our moderator, Dr. Ramesh.
If you invite madam to this thing, I can congratulate her also.
Our next topic, approach to status epilepticus by Dr. Devendra Mishra. Moderator will be Dr. Aram Chandra.
Hello, good evening, Dr. Devendra Mishra.
Just lock it. Just lock it. Nature.
Hello, sir. How are you?
The next topic will be approach to status epilepticus. Okay. By academician par excellence and editor-in-chief of Indian Pediatrics, our own CAP journal. Really, it's an honor to chair this session of sirs. Actually, we know that seizures, be it febrile or non-febrile, is a common medical emergency that need to be controlled early by primary care pediatricians. So if there is a delay, it is going to go for status. So definitely, there should be a prompt recognition, and management is very crucial for optimal outcome. Let us hear from the great academician. Over to you, sir.
Thank you, sir. Thank you for the introduction, and I thank the organizers for the invite. So we have been hearing about history and examination throughout the day. And this is one condition where prior to history and examination, in fact, you need to give the treatment. And treatment is in fact more important in this condition rather than many other pediatric emergencies, because as you delay treatment, the outcomes worsen and the response to treatment also worsens. So, and an important thing, most of the people who are senior here would, once they go through the presentation, will feel what has changed. And really, not much has changed over the last almost 3 decades in the management of status epilepticus. And why is that? That is because there are 2 problems with it. Neither we understand the disease. Epilepsy, we do not know why epilepsy occurs, really, at a molecular level. And on the other hand, we don't know how the drugs work. You read the books, every drug is sodium channel blocker or GABAergic or AMPA blocker or something like this, calcium channel blocker, potassium channel blocker, potentiator. But really, which drug works by which mechanism, we don't know. So neither we know how the disease occurs, neither we know how the drugs work. So in fact, we are really working in the dark for management of status epilepticus per se. But still, a lot of research has been done over the last 5 years, which has given more knowledge into how the drugs work in status epilepticus and what is the way forward to get the best outcomes from status epilepticus. So I will just try to run through what we know about status epilepticus, primarily about management, but something about workup also. So it is common, as most of you will be working, will know, commonest neurological emergency in pediatrics. And it is associated with high mortality and morbidity, but thankfully in pediatrics, mortality is much lower. It is around 3.5% as compared to almost 16%. So almost 1/5 of the adult mortality. Incidence, now more research has been coming. For a long time, we were just talking about 20% incidence per lakh per children per year. Now in the developed, that is the developed country data, new data from Asia shows it is almost double in the developing countries, probably because of higher occurrence of infections. And with the pneumococcal vaccine coming up and being taken up on a large scale, JE vaccine, probably these will start coming down to those levels. But the highest incidences in those above less than 1 year. There is mortality, we have already talked, it is lesser in children. Cognitive and motor disability. Very frequently, once the seizure is controlled and we do not find a cause or find a cause and treat, the patient goes off and we are not really following them up for at least the cognitive damage, which has been in some studies shown to be up to 50%. Although it is more commonly dependent on the etiology of the status rather than on the status per se, but follow-up patients of status epilepticus, up to 50% of them may have cognitive, new onset cognitive or motor disability. It requires immediate medical, all emergencies require immediate medical intervention. But why it is important for status epilepticus, I'll just come to it after a few slides. So Thiruvallur said that for any illness, you diagnose the illness, trace its cause, seek the proper remedy and apply it with skill. So I would go with the plan like this only. We'll just see the definition, what are the etiologies, and then how to manage. So this is a very complicated definition which has come up of time point T1 and time point T2 related to seizures. Primarily, it means that status epilepticus should be defined by two time points. One is when you need to provide treatment, and the other one is when permanent brain damage may occur due to the state. So for that, for generalized tonic-clonic convulsive status, the T1 is 5 minutes. You have to start treatment within 5 minutes, and within 30 minutes, continuous seizure activity, you may have brain damage or neurological damage. For focal seizures, this T1 is 10 minutes. You can wait for continuous seizures, even 10 minutes for treatment, and T2 is 60 minutes. There are three operational definitions you need to be aware of, which is required for the management purposes. Any generalized tonic-clonic convulsion which is continuing for 5 minutes, or there are multiple seizures without regaining consciousness for 5 minutes, you have to start treatment, labeling it as status epilepticus. Most of the studies now, previously we were taking the definition of 30 minutes, but since 2015, this is the operational definition is being used, and the newer trials all are using a definition of 5 minutes for starting treatment. Refractory status is whenever your seizures do not respond to the two classes of drugs. So initial benzodiazepine plus one more drug, it is a refractory status epilepticus. And as you would be aware that the initial benzodiazepine means you give 2 doses of the benzodiazepine. So 2 doses of benzodiazepines and another class of drug, whichever you give, and there is resistance to no response to that by seizure cessation, then you label as refractory status. And then, of course, there is a super refractory status, which is usually previously said to be more than 24 hours. Now it is labeled as that third line anticonvulsant or anesthetic drugs. There is no response for 24 hours. Then you label as super refractory status. And why is this important? I'll just come when we talk about a pathophysiology of it. So this T1, T2 conundrum I have already talked about. GTCS, start treatment within 5 minutes. Try to start treatment, and long-term consequences will be expected in 30 minutes of continuous seizures. For focal status, especially those with impaired consciousness, this is 10 and 60 minutes. And absence, we do not know whether absence status really cause brain damage even if they are prolonged, but you should start going in for treatment at 10 to 15 minutes. This term, I will not be talking about the treatment of NCSC or investigations, but just to give an idea that non-convulsive status epilepticus is a common entity. There are no motor manifestations here, and you need your clinical skills to really identify a non-convulsive status epilepticus. The two common scenarios where you are likely to find non-convulsive status epilepticus is a child who is recovering from a convulsive status epilepticus, so no motor movements now. You have given sufficient drugs, but still the child does not regain the previous level of awareness or consciousness. Then you should definitely think of a continuing non-convulsive status or an electrical status and need an EEG to diagnose that. And the other group would be sick babies. Studies have shown that sick patients admitted to PICU, up to 18% of them may have non-convulsive status epilepticus. Mind you, these are non-neurological illnesses. So be aware that any patient of any illness was sick enough, and now the behavior or the consciousness has not returned to normal, you should think of a non-convulsive ongoing status. Etiology, no specific etiology for status epilepticus. Any condition which can cause seizure can also cause status epilepticus. But Western literature, as I will show you, you will find that prolonged febrile seizure is the commonest cause in pediatrics. Whereas for all Indian studies, you find neurological infections as the most common. Just see, developed countries, most studies will show up to 30%, even up to 40% is febrile seizures. These are pediatric studies. Indian studies, hardly 10%, 14%. Even in study from Bihar, it is only 3%, because most were 47% for acute symptomatic, mostly CNS infections. NEMA study, again, 34 CNS infections, rest for CV. So this is again a status epilepticus study we did. And again, we found most were CNS infections, 54%. But another important group which you need to know is the green color one, non-compliance in epilepsy. So the reason is not known, but if a child with epilepsy who is receiving anticonvulsants has non-compliance, very frequently they go into status rather than having a breakthrough seizure. So status epilepticus as is due to missing drugs in epilepsy is an important group which you need to be aware of, and that's why that is one of the reasons that for children with epilepsy you need to advise them to adhere to their anti-epileptic therapy. So the gist is that this is the operational classification of a status. That there is an early status epilepticus, which period is up to say 20 to 30 minutes, where you should provide the stabilization and the initial therapy. Then there is a established status epilepticus, where second and third line therapies are to be given, and then comes the refractory status epilepticus, after which the status becomes much refractory to the usual anti-epileptic drugs, and metabolic derangements in the body start, and then probably you need to have more intense care, or probably a ICU setting you need to manage the patient. Pathophysiology, really I didn't want to go much into it, but one thing, important thing with pathophysiology has an implication on treatment is that the initial 30 minutes homeostatic mechanisms are intact and they meet the metabolic. So there are not much metabolic derangements in the body. Most of the process is limited to your central nervous system during these initial minutes. Later on, cerebral autoregulation will feel there will be localized metabolic lesser metabolites available. There will be localized neuronal edema. So in addition to the actual damage due to the seizure discharges, there would be more hypoxic and ischemic damage to the brain. And much later, in the stage of refractory, what happens is that the GABA receptors, they are internalized. So they go in. So the drugs like benzodiazepines or phenobarbital, which are work through the GABAergic mechanism, they start failing. And at this time, NMDA and AMPA receptors, which are otherwise subsynaptic, they will come into the synapse. And now probably the drugs which are effective are those which act on these receptors, probably ketamine or drugs like perampanel, which have these mechanism of action on these receptors, and they will. So how do we go about managing this? Any ideas? So usual, we tell our undergraduate students also 3 steps. First is stabilization, ABC, which you all know. Although we know that maintaining airway in a seizuring child is very difficult, but still, and prevention of injuries. Stabilization, preferably we want 2 IV lines, 2 IV accesses, one for the drugs and one for taking out the samples for the workup. Which workup you want to do in a patient with the status? Anything? Which electrolyte you seen in a patient having status epilepticus or a seizure? So in patients, usually patients admitted for the other diseases, usually sodium, otherwise hypocalcemia. Under children under 2 years, one study showed up to 75% of them having hypocalcemia as a cause. But that usually afebrile. So that is the only metabolic. I think glucose, getting glucose, especially in under 2-year-old infants and toddlers, and calcium would be the initial investigations you will want to get. Prior to that, I just stressing on the out of hospital minute. Important thing is the response to benzodiazepines, and multiple studies have shown that poorer outcome and higher mortality is related to age of the patient, definitely, etiology of status epilepticus, of course, and time to the onset of the from time to onset to the first drug. So if you give the first drug early, there are more chances that the status epilepticus will get controlled and will have a better response as compared to delaying it. And in the Niemann studies, there were patients who had been coming at 80 hours after the onset of seizures also. So at 80 hours or from distant places. So at 80 hours or something like that, or I doubt if whether giving benzodiazepines or using the normal status epilepticus protocol would really work. So parents are first responder. Those patients who are already having epilepsy, diagnosis of epilepsy, you can always advise intranasal midazolam, which is available commercially also for breakthrough seizures, especially with patients with Dravet syndrome. Madam, previously we were talking Dravet syndrome, where they frequently get status epilepticus. You can prescribe them nasal midazolam for home treatment of seizures so that they do not progress to status epilepticus. Or rectal diazepam is available. Even if it is not available, even the syrup through the per rectal route works as well as rectal diazepam. Or buccal or intranasal midazolam, lorazepam is not available, but in the process and should be coming in commercially in a year or so. Remember, for those who are in inpatient care, inpatient practice, hospital practice, patient who has come to you with the status epilepticus or with continuing seizures and has received benzodiazepine at home or while being while coming through the ambulance, in the ambulance, you have to count those doses also. So most protocol will say give benzodiazepine, whichever you are giving, and then wait for 5 minutes, no control of seizure, give another dose. So if the patient has already received one intranasal midazolam or rectal diazepam, count that as the first dose. The one you give by injection would be the second dose, and then go on to the next line of treatment. Do not start the protocol from the beginning again. Stabilization phase. This I've already talked. Position, stabilize, secure IV access, samples, check dextrose, which is immediately available and you can immediately manage. Rare to find hypoglycemia as a cause of seizures in children older than 2 years or non-sick children less than 2 years old. So a child who is absolutely well just throws a seizure or continuing seizures, very unlikely will find hypoglycemia as a cause. But definitely you need to get it done and out of the way. Simultaneously, history and examination if there are any clinical clues. However, treatment doesn't change with the clinical clues. You have to go according to the protocol. This is IEP guidelines on management of status epilepticus. These are old, almost 9 years old. Another one is in the pipeline, but the principles remain the same. If the child is less than 2 years, hypocalcemia has been shown to be an important cause, at least in the Indian setting. Get ionic calcium, dextrose, of course, we have talked, sodium, as most of you are agreed, and that's all. If the child is febrile, CBC and lumbar puncture whenever seizure gets controlled. In a seizuring patient, you can't really do a lumbar puncture. Second line, after the seizure is controlled, probably you will get an MRI or EEG if needed. That is second line. And if there is a suspicion, this is Western literature, not much Indian data on urine toxicology screen. But if really you want to do toxicology, especially in a child with epilepsy, get serum phenytoin sodium done. Very frequently you will get seizure patients with status epilepticus and some dystonic posturing, and what they had was they were having epilepsy and were prescribed syrups, phenytoin sodium, and syrup phenytoin sodium is a suspension. And what happens is that initially, if they do not really shake the bottle, what happens initially, they just the diluent they are giving, and epilepsy is not getting controlled and the dose is being increased, and later on in the bottle, more of the drug is going in. And they get go into a status epilepticus. So preferably avoid, or even we have also in fact written to the government to ban, but I think that would not be possible. But avoid a syrup phenytoin. You can easily give a tablet phenytoin, even if you are giving it to young small groups whenever you are prescribed. So non-epileptic with status epilepticus, AED level is an important thing, whether your levels are low or not. This is important because if it is the status is because of a low level of anti-epileptic, you can just load with that particular anti-epileptic to which the child was previously responding. And again, everything is same as before. Non-patient with epilepsy without precipitating factor, again same, calcium, dextrose, sodium, febrile the same. But in second line, again, despite no history of non-compliance, you can again get the anti-epileptic drug levels. And continuing status epilepticus, you need to get, that is the when metabolic derangements are starting. We are continuing status epilepticus. Probably electrolytes you will need to get daily, LFT, KFT daily, ABG monitoring as needed. For patients with refractory status epilepticus or super refractory status epilepticus, once initial evaluation has not revealed any cause and there is no response to treatment, also probably you will like to work up for metabolic causes, autoimmune causes, and genetic testing probably later for the cause. So what is the initial therapy? Almost everybody is clear that we want to give a drug which has a rapid onset of action and high efficiency. So benzodiazepines are the proven drugs for this. You can use any benzodiazepine, lorazepam. Westernmost protocols will say lorazepam because that is easily available. IV diazepam. Many of us have good experience with IV diazepam also when lorazepam or midazolam are not available. But midazolam is now available. So midazolam also. So these are equi-efficacious, no superiority over the other. Sedation potential or respiratory depression potential, diazepam has the highest, midazolam is lesser, lorazepam the least. Doses are here. If there is no IV access, midazolam is the drug of choice because you can give it as IM. Though the response is slightly slower, you can give intranasal spray of midazolam if it is available in your emergency. You can also give the injection diazepam without the needle in the buccal area. So if you can't, if there is a focus, especially with the focal seizure, it is possible. In the generalized seizure, you are unable to really open the mouth. But with focal seizure, you can just hold the head and give the injection midazolam without the needle, put it in the buccal area between the teeth and the cheek, and that also works fast. So if you have no IV access, these things can be done. But in the hospital setting, we did it as part of a research, but it is otherwise difficult because two people are already trying to put in a cannula and the child is already seizuring, and then you're putting buccal midazolam, somewhat difficult. So best thing is keep a nasal spray of midazolam for if you don't have IV access. Seizures not controlled in 5 minutes, another dose. I'm writing it in this slide again that do not miss counting the. Otherwise, you are just wasting your time and in giving repeated midazolam, whereas it is unlikely to. Till this point, everybody agrees that this is the sequence and we have to do. For the second line therapy, there is lots of quandary, lots of literature showing this drug is superior to that. And we have seen it over the years that whenever a new drug comes, a bunch of studies come that this drug is superior to the others pre-existing drugs. And later on, it fizzles out. The publications also reduce. And in practice, we see that most of these are almost equi-efficacious. Same with status epilepticus. Previously, Veterans Affairs trial was in 1998, 1999, and that showed that phenytoin is superior to the other anti-epileptics as a first drug after a benzodiazepine. So that was the reason most protocols were using phenytoin. Now, in the last 5 years, 4 trials have come, 1 in adult and children, and 2 in children only, and 1 is a meta-analysis. So all are showing that phenytoin or phosphonitoin, whichever you are using, is almost equi-efficacious to valproate or levetiracetam. So these 3 drugs are equi-efficacious. You can try any of these. The only limiting factor would be either the cost in our setup or the side effects. So most of the trials have been done with phosphonitoin. None of these trials is with IV phenytoin, which most of us are using, at least in the government setup. Levetiracetam, most of the trials have used the higher dose of 60 milligram per kg as a loading dose. Phenobarbital, as you may not be aware that in the Veterans Affairs trial, the most efficacious drug shown was phenobarbital. It was in fact superior than benzodiazepines as the first drug for seizures. But it went into disrepute because of its respiratory depressant capacity. Because of the respiratory depressant side effect, along with the benzodiazepine, it causes significant respiratory depression, and that's why it went into misuse. but now it is coming back again, especially as a treatment of super-refractory status epilepticus at very high doses of up to 30 milligram per kg. So, this issue of which drug to use after a benzodiazepine depends on your local condition and your local protocol. An important issue which I want to underscore here is that comparison of outcomes among hospitals for status epilepticus has shown that institutes which are using a protocol-based therapy management have a better outcome as compared to non-protocolized treatment. So whatever protocol is there, your institute or department develops, use that one rather than choice-based that one resident or one doctor is on duty, he gives one dose, next person comes, they give a different drug. That usually is associated with the poor outcome. So general principles, none is superior. Either of these can be used depending on your choice or your protocol and individual patient characteristics. Some caveats for valproate, because that is the other one which is the most commonly used, is if there is significant hepatic dysfunction or the child is less than 2 years. Less than 2-year-old children, acute fulminant hepatic failure has been idiosyncratic hepatic failure has been reported with use of valproate, probably in undiagnosed IM, I think. So we should try to avoid. And if you have a suspicion of a urea cycle disorder or a mitochondrial disease, try to avoid valproate. Phenytoin, road traffic accident patient or those with those with CHD and throwing a seizure, probably you will want to avoid phenytoin. It has significant cardiac toxicity and causes hypotension. And if somebody is on multiple drug, levetiracetam, which has the least drug interactions, you would prefer. Third therapy phase, you have given the second therapy drug and there is no response to the drug. And now we know that the patient is into refractory status. Now there is a choice. The first one is a better one. Either you go for another drug, another second line agent, or you go in for a continuous infusion. For a continuous infusion, you need to usually keep the patient in the ICU. So depending on the ICU bed availability situation in your institution, you may decide on these. But most of the protocols are now coming around to the issue of giving another second line agent, because it has been shown that most are equi-efficacious, and multimodal management of status epilepticus is a principle which says that if one drug fails, we need to use another mechanism of treatment for the status epilepticus. So use another second line agent, whichever you have not used. What we want to do is reduce brain damage due to status, that is reduce the duration of the continuing seizure to less than 60 minutes. And your choice will frequently depend on the availability of ICU. If you do not think about giving the second drug, or if you have given the second drug and still there is no response, then you go for IV infusions. This can be a continuous infusion of midazolam, or you can go in for thiopental or diazepam. And the other one, phenobarbital at high doses phenobarbital for refractory status. Midazolam is the usually preferred. I'm working in a government center where we don't usually have the PICU beds available, and we have to manage even after using two second line agents. Still, if the seizures are continuing, we are managing them in the wards only. So we go in for continuous midazolam infusion, which the dose after loading dose of 2 milligram, you give 2 mg per kg per minute infusion, and your infusion can go to up to 18 mg per kg per minute. And usually what we try to manage in the wards is up to 10, and after that you will definitely, the risk of respiratory depression will increase, and you will want to shift to the PICU for beyond that. Ketamine is coming up now as an important drug for refractory seizures because it has a proposed mechanism of action against NMDA receptors, which are the most important receptors at this time, which are contributing to the continuation of the seizure activity after 1 hour of continuous seizures. important thing you need to see is that again, ketamine also using it early. Within 3 days of seizure onset, if you use, it is 64% efficacy as compared to within half of 26 days or more than 15 days. The efficacy reduces significantly. Probably by that time, even the NMDA receptors are also not working. The AMPA receptors are the primary risks. So this is the standard treatment guidelines of IAP, which state the same stabilization, general measures. So this I have already told that the use of midazolam drip is up to 30 mg per kg per minute, but beyond 10 mg per kg per minute, you shouldn't try to aim in the PIC, outside the PIC. What other modalities, once all of these do not respond, there is no response to these, you can use oral topiramate. It has also some action against AMPA, proposed action. You can use it through a feeding tube. Usually there is some response. 30% is the response which is claimed. Lacosamide is now available. Lacosamide injections are also available. That is another drug which you can use. Important thing is that it is available IV. And remember that lacosamide has more effect against focal seizures as compared to generalized seizures. So if focal status epilepticus is there, definitely lacosamide would be one of the drugs you will want to use. There are the initial reports. These drugs are on the horizon. Brexanolone. Perimpanel is important one. Adults, many trials were stopped because there is a risk of increased risk of suicide. But because of its action on AMPA receptor, which is an important receptor during the super refractory stage, this is now coming up for use during status epilepticus. Brivaracetam is a levetiracetam congener, which is being brought for specifically for status epilepticus. Ketogenic diet. We have just tried it in one patient, but we don't have the facilities for ketogenic diet at our institution. We have to send to some other place. But still, that is an effective management option. 1/5 of the patient of status epilepticus without a autoimmune encephalitis cause, like diagnosis is not autoimmune encephalitis, may respond to ketogenic diet. So once the disease has become super refractory, these are continuing seizures through in and out many days. Ketogenic diet can be tried if facilities are available with you, especially with patient who has been sedated and is being ventilated with status epilepticus. Giving ketogenic diet is quite easy as compared to a patient who is conscious and awake, because the palatability issues with ketogenic diet frequently occur. Here you have to use the diet through feeding tube. So that way it is possible earlier to achieve ketosis and see response. Therapeutic hypothermia, this is an old slide, not of any use. Recent evidence shows it does not have this. The recent trials show that it does not have any effect in status. Of course, now is the time when the patient goes into super refractory status. You need to now look for the etiology and imaging and EEG. By this time, you must be hooked on to an EEG, but you need to get an MRI to identify if there is a possibility of any other etiology. Most important for a status patient would be an autoimmune encephalitis, which of course in MRI is infrequently picked up, or an epileptogenic foci, which may be possible to resect, it may be possible to resect on by surgery. TMS and ECT had come previously, electroconvulsive therapy and transcranial magnetic stimulation for management of status, but just few experiences and no major studies have supported their use. Autoimmune encephalitis, either it's coming up too much in recent times or it is being diagnosed more frequently because of the availability of the test, and many of the undiagnosed status previously are now being diagnosed with autoimmune encephalitis. So if you diagnose these, then immunomodulatory therapy is the treatment of choice, and the anticonvulsant therapy or anti-seizure medications would not be working in these. For these, you need a serological diagnosis. Serological diagnosis would be a CSF autoantibody testing. That only makes the diagnosis. Nothing more to say. EEG, there you may be extreme delta brush finding is there in some of the NMDR encephalitis, but very difficult to get this reported by the neurologist. And also it is a rare finding, up to 10 to 17% they say. So majority will not be having this. The inhalational anesthetics, probably the ball is now out of your court and the anesthetist or the intensivist have taken over the patient, and this is the last agents of last resort. However, mostly you will find that there is response to these initially, but once you start tapering, they will start throwing seizures again. So neuroimaging in initial phases, you do not need status epilepticus neuroimaging, and probably after the control of status for the etiological purposes, you may need depending on your history and examination. Otherwise, during the actual status, you will just require neuroimaging for an epileptogenic focus. EEG, once the child's status has stopped, you may want a EEG if the child has not regained consciousness completely or there are behavioral issues, or EEG may occasionally pick autoimmune encephalitis or for control of seizure. So if you are giving inhalation anesthetic with muscle relaxant, you may want to monitor the EEG activity to see whether the seizures have really controlled or not. How do you do follow-up? Anti-epileptic drugs can be tapered off prior to discharge. Somebody who has got a status epilepticus and imaging is normal, you do not really need to give anti-epileptic drugs for long, unless there is a lesion which is the cause of the seizures and you feel that long-term anticonvulsants are needed. Recurrence risk after the first episode of seizure, status epilepticus is same as recurrence risk after a first seizure. So you can safely taper off anti-epileptics after the status epilepticus. Now is the time when EEG and neuroimaging may be required for the etiology. What are the outcomes of status? Around 25%, 5 to 36% they say is the subsequent epilepsy, which cannot be prevented by use of anti-epileptic drugs. So you have to make a diagnosis of epilepsy later before thinking of starting long-term anti-epileptic drugs. This is evident in non-febrile structure and remote symptomatic epilepsy. Definitely, there are more chances. Somebody with a febrile seizure or with a meningitis and a seizure or a status is unlikely to go on to have epilepsy subsequently. Just see this one, predictors. Recurrence risk predictors are less than 4-year younger age, remote symptomatic etiology, and failure to respond to first AED. So response to the AEDs are important issues. Even for the second AED, the drug to which the status responds, it is preferable that when discharging and you are planning to give long-term anti-epileptic, give that drug to which the status responded, because it is likely that the patient seizures will respond to that drug. Very frequently, we see that patient required 3 drugs for control of status and has been discharged on all 3 drugs orally. So that is not needed. You can discharge on a single drug if you decide. What is the way forward we are thinking of? So there is already established global literature on pre-hospital management, importance of pre-hospital management. Initial abortive therapy, that is benzodiazepines, and post-benzodiazepine first line therapy. There is almost global consensus that all the drugs are efficacious, equi-efficacious, and either of the 3 drugs you can use, valproate, phenytoin, or levetiracetam. Phenobarbital, with a caveat of side effects and respiratory depression, you can definitely use, more efficacious than these 2. Not much work is being done on phenobarbital presently as a second line AED. Most of the work of phenobarbital is being done for super refractory status. But further research is needed for refractory status and super refractory status and other therapeutic pathway. The way we have come to know that autoimmune encephalitis will not respond to your anti-seizure medication rather to immunomodulation. Similarly, inflammation or mitochondrial etiologies may be there for many of these status epilepticus which do not respond to your anti-epileptic drugs. The most important thing for status epilepticus is prevention of progression of a single seizure to a status epilepticus. That is, if there is a seizure at home, we have to train parents to take, or first responders. Like in Delhi, the CATS ambulance has two persons, the driver, and there is a paramedic also who can give some medications, but the tray does not contain, in fact, injections. They are not permitted to give injections. So they just have per rectal diazepam, and we had a training session with them to train them to give how to give per rectal diazepam. So similar issues remain. So even if the first responder, by chance they are reaching to the child, they are unable to, in fact, give medications. But we have to train at least those parents who have a child with epilepsy, how to manage the seizure and prevent progression to status. Use a protocol, any drug of the second line. Avoid SVA if it's a younger kid or you are suspecting an inborn error of metabolism. And that's all. Further study should focus, I think. Just to revise, again, 5 minutes, stabilize IV access, sample, electrolytes, dextrose, calcium, 5 to 20 minutes, give the benzodiazepines 2 doses, 5 minutes apart. If the patient has not received an out of hospital dose, 20 to 40 minutes, give one of the second line AED, 40 to 60 minutes, either try another of these drugs or go to a continuous infusion for it. Thank you.
Thank you for the neat and algorithmic approach for status epilepticus. I think the floor is open for discussion. Any questions? Right. Sir, yes, sir, Mike.
Sir, I enjoyed your excellent lecture.
Thank you, sir.
I have one person who got 28 points 30 years back. At the time, we are using pediatrics. It can be given intramuscularly. It does not have a side effect of a serious depression like Windows, like phenobarbital. But unfortunately, I think it's a forgotten. What is this vision role? Any idea?
So paraldehyde, none of the literature is supporting. We published a paper in 2001 on use of paraldehyde for neonatal seizures. So it can be given intramuscular. It is oil-based paraldehyde. It has pulmonary toxicity. It does not have hepatic excretion. So it is neither hepatotoxic nor renotoxic. And it has good efficacy also. The problem is that not much literature is available. It was used previously, but not much literature is available. So once literature becomes less available, the drugs becomes less available in the market. And even phenobarbital is going out of the market. We really have trouble sometimes to get phenobarbital. So paraldehyde, sir, no, not much evidence now. But it was good drug when it was in use. Yes, sir.
Excellent talk.
Thank you, sir.
One question. For the breakthrough seizure, if the patient is already on a particular drug which they have missed, would that become a choice of drug in this segment?
Yes, sir.
Give an example, if the patient was on valproate, would I choose after benzodiazepine in a breakthrough seizure? Would I choose valproate as a choice?
Then it's gone. Oh, huh. So So I've didn't read this up. So if a patient has a breakthrough seizure, is on valproate. If it is valproate dose is up to 60, I think 60 milligram per kg, you can try. So if it is below 30, you can give a half loading of that drug after benzodiazepine, because we think that probably the seizures, breakthrough seizures, is because of low valproate. But if it is, let's say 40, you don't want to load with valproate again, maybe go into toxicity, better to use another.
I got a question.
Same with all the drugs, sir. rough idea is less than 50% dose, you load it with half loading. If not less than 50, then go for another.
How far the serum drug level or the anti-epileptic drug level is going to help the clinician or at the ICU?
It does not. Serum drug level has no role in management of status epilepticus. So the 2 or 3 reasons I would think of is, one is the toxicity. For that, it is very important, and just remember that for toxicity, it is better to have a post-dose levels rather than you want to measure the highest level of the anti-epileptic which is there in the blood. So preferably post-dose. And for efficacy, you want a pre-dose level. So before the next dose, you take a level so that you get to know the minimum level of the anti-epileptic which is there in the blood. But for status epilepticus, it does not help us, but it is a second line investigation. So if a patient with epilepsy who is already on one anti-epileptic drug, we would need to get this once we have gone through the initial 2 steps, because high levels of at least phenytoin have been shown to have associated with status.
Yeah.
And if the levels are subtherapeutic, we are sure that it is non-compliance which is the cause of status, and then we can use the same drug.
If it is suppose it's febrile seizures and the pre-drug level is probably not inadequate for the control of seizures, that could be the reason.
But the current, you are saying the drugs which you are using currently.
If it has come just for the first.
There is a febrile seizure patient came which has never received any anti-epileptic, and now we have loaded with benzodiazepine.
That is not probably sufficient enough. That can be actually taken care of if the drug levels are measured as a pre-dose.
No, sir, because previously you must be remembering what we used to do in status is give 20 milligram per kg of phenytoin, no response, give 10 more. Pneumatology we still do. Half loading is given sometimes again. But now the new concept is that you are giving the drug IV. Where will it go? It will go into the blood only. And we do not have a predefined level of therapeutic effect. This is a range like 8 to 12 for phenytoin. So some patients may be controlled by 7 also, and some patients may not have toxicity with 13 milligram per deciliter. So it is the principle of multimodal therapy says that if no response to one drug loading, go for another. There is no issue.
Thank you, sir.
But in the third, like in the ICU, probably you will want to do the drug level, but not in the initial phases.
Thank you.
Thank you.
Thank you.
I request Dr. Arup Settal to felicitate our speaker.
Thank you so much for coming over.
I request Dr. Sharmunathan, Organizing Secretary, to honor Dr. Arup.
Break off for lunch.
We break off for lunch for half an hour. We have our panel discussions and quiz post lunch. Thank you.
Yeah, please reassemble at 2:15 sharp, please. Yeah, 2:15 sharp, we'll start the next session, so please reassemble.
Dr. Janani would have pen drive of the pen drive is the link, sir. Wait to put 10 phone from the orange color. இந்த ஓரேஷன் கொடுத்தாங்கல்ல
ஆமா அவங்ககிட்ட இதை கொடுத்துட்டேன்.
கொடுத்தீங்களா
பிங்க் கலர் சம்திங்.
ஆரஞ்சு கலர் மேடம் இல்லையே மேம் போல உங்ககிட்ட கொடுத்துட்டேன்னு சொல்றாரு அவர். Can you check? Definitely podiumல இல்ல. Yes. Okay. Okay, he is saying and he removes the color also. Yeah. இங்கெல்லாம் இங்கே இல்லை இல்லைன்னு
And then I came back here for last 2 months. Just now, that way. Assign somebody and then not let them take over and then talking as the doctor will be thought this so that they ultimately it was then yeah, there are enough of people. Yes. Yeah. To use stuff, you can definitely start something here.
Symptoms are different. But then on the 130, so 330 or 1 that's that they are on the sub of the responsible. My time. Someone was not going. Now I just got out. I'm then I make it. Start with such an end of the if you were to try, wow, and what's part of that? What can back you? Na correct, so the mix of reality of guest can shelter into the hour without computer. அதே மாதிரி மார்னிங் 6 o'clock போட்டி டெஸ்ட் போட்டி கேரம் போட்டி வேணும்னு ஓடிட்டு எல்லாத்துக்கும் இருப்பாரு ஆரம்பிச்சு அளவு பண்ணிருக்காரு தம்பி போய் தம்பி போய் எங்க சிஸ்டர் எல்லாம் அதுமாதிரி மேரேஜ் ரொம்ப அது மாதிரி இருக்கும்போது ஏதோ ஒரு கிரீட்டம் கேர்ல அப்போ வந்து ஆஸ்திரேலியன் போய் ஆஸ்திரேலியா or then there was one absolutely not that much. But in realize, of course, especially not so good. But it is the devil. Beyond that, many times both parents are working. So I'm not sure the urgency. Emergency will take time. Yeah, it's not really when I get people unbelieve. There's people find you know. Okay, then I'm you will love on the job. But I think it's a work. And they talk about your name questions. But even on some of the memory, tell no one or so that went for still yes. I'm not sure from there.
40% of it mental best. And so it's not so much now. I just Yes, I'm telling it's my children. There's no super dog. And then that's very I'm just all the taking of it. So it's the software. Second, we need to some social in the I mean, it's much like it's James on the green. I'm studying it. Oh, it's like Papa Bear. It's done. Yeah. So, I can nice. That's very good. Meaningful. That we better come over. That box better. I could really believe. What I want to be. Really, for last. See the hands. And make me an inflate this hand. If you are saved, they will all. Then, it's not really my money. How do we know? Yeah. It's a we are getting I mean, rest of the yeah, let's not put out. Sorry. Yeah, it is that's just they're in right and they are I'm not worried.
discussion, the problems in so much in unity. And the started off this time. Because you got it's not about school. Like the sort is promoted. You're definitely problem. You're and the problem. I don't know this serious. That's harder for the big. I love the seat of the way. Who knows that person? Everybody is on. Everybody. No, that's having not amazing that in that it's a slow pace of others and it's everything. I know it's not just like a really that looks bad and try to good growth and when you say that in body, I do a tough I don't say I'm not ready. Or after the I was in. I mean, it was. I go. I said,
Welcome back. We start a session with panel discussion on short duration fever with emphasis on viral fever. Our moderator for the session will be Professor S. Mahadevan. The panelists will be Dr. C.G. Dellikumar and Dr. R. Ramanathan.
So song from him. Somebody something. Question. So summary question.
First, fever without focus. Question for the panel. Question is for the panel. Question. This one. Hello. A very good afternoon. A very good afternoon to one and all. And I thank the organizers, Thiru, Arun Sendil, Dr. Ravi, and all the other members and the audience for this opportunity to meet with you. Now, this is an important, that is how I think they will straight away. And then after that, we are always used to the medicine way of what is known as PUO. So that is a long duration fever. Whereas now in pediatrics, so the short duration fever is something which we deal day in and day out. So for this, I think I have two very eminent co-panelists with me, Professor Ramanathan from Chidambaram and Professor Dellikumar from Jitman. And it's a pleasure to have them because for the last 3 days when we interacted, how to organize this thing, this is the idea which came out from them, that we are going to ask for 4 questions from Dr. Dilli Kumar, and he will present certain things related to these 4 questions. And then Professor Ramanathan, these will be the 4 questions. And as a concluding remark, I will give certain parting thoughts. Plus, the last 5 minutes will be for a shared understanding from the audience. You please share your stories, because I'm telling you, the mind is a storytelling machine. And in fact, the stories make a lot of difference. And this is what comes as a problem-based learning. You have a problem-based learning. From that, you develop your questions, you develop your way of teaching. So as a result, when you share your own experience, and I think there is nothing more valuable than that. And as Dr. Janani today said, that students, patients are our textbooks. The textbooks are there for us to go and verify again what has been the experience elsewhere. So with this introduction, let me ask Professor Ramanathan to take the stage and answer these 4 questions. Red flag signs, plan of actions, do's and don'ts. What could be a point of care decision, especially there, the role of CRP. This is has come up in a big way, and medications which you use.
Good afternoon, ladies and gentlemen. Initially, we thought we will be standing in between the biryani and the audience, but now it's even more worse. It's post biryani. So I hope you will all be listening to this session, because it's very important session of day-to-day affairs. The most important complaint that a mother or a parent comes to us is with fever. So every day in and day out, we are facing these situations. With due respects to our moderator, Dr. Mahadevan sir, and all the senior professors, the doyens of pediatrics in front of me, it's an honor for us to present in this session. So now we will just go through the important points that sir has highlighted already. We are going to discuss about short duration fevers, and with special emphasis to viral infections. So I will not be touching about many of the other bacterial infections which can present with short duration fever. We will be focusing only on the most important viral infections, because so that we will be aware and we will not be misusing antibiotics, because nowadays antibiotics are used irrationally, and even meropenem has come in an oral format, and the pharmaceutical companies are promoting them left and right. I'm not sure whether URT is going to be treated with meropenem in the near future, and we will surely be landing up with not only super bugs but super square bugs also in the future. So probably we should be aware and we should resist all these drugs from being used in the common scenarios. Probably post ICU, when they step down these drugs, we can use those drugs, but they are promoting it for every day-to-day conditions. So it's a very dangerous situation for us, which is in front of us. So now these are all some common terminologies that we would like to know. All of you are aware of these terminologies. I won't waste time on these things. This is the first one is an acute febrile illness, which we commonly write for any child who comes with fever to us in the OPD or in the casualties. So acute febrile illness is any child who has got a fever. So just one point I would like to add here is, after you write this diagnosis, please write 1, 2 and tell us what you think. Probably this is a viral fever, probably this is an otitis media. Number 3, it could be a pharyngotonsillitis. If you go into the next level, you will be thinking of what the exact cause of fever is. If you just write acute febrile illness, sometimes you will not be examining the child properly and you will not come to localize a proper diagnosis. So that would like to request all of you to go and write 1, 2, 3 in your practice also, so that it will be good for you. Then the second one is, usually we write fever without focus. When you do not have any focus in a particular child, either the child really does not have a focus, or we have not given a focused approach to examining the child and we have missed this particular finding. Many of the times we send these children to medical colleges, we refer them from a busy private practice, and the postgraduate there easily picks up the findings. Many of the times they pick up an HCAR which is hidden somewhere. They pick up a poor peripheral pulse and diagnose myocarditis, because they have more time than this and they do a systematic examination. So that is what we should also try to impart in our practice, and give some time for these high risk patients, and especially children who are having these red flag signs. Then your Nelson says fever more than 38 degrees is called as fever, and hyperpyrexia is more than 41 degrees centigrade. So just remember these two important landmarks of this temperature. And Helicobacter is once you have a positive culture, but there is no focus, and it is a well-looking child. It is not a very sick-looking child. So previously, before the introduction of Hib and the pneumococcal conjugate vaccines, we used to have this particular terminology, but now slowly it is going out of the educational system because Hib and the pneumococcal is completely covered even in the government sector. Nowadays, the government sector is giving more vaccines than the private sector. We should be very thankful to the government. At 6 weeks, you have all the 4 limbs. 10 months, you have all the 4 limbs. The parent comes and says, "Rendu kai, rendu kaal, why? Ellame mudichitaanga sir." So that's the amount of vaccine that we are using nowadays. அவன் வந்து வேற ஏதாவது இருக்கான்னு கேட்பான், இதுக்கு மேல ஒண்ணும் இல்லை, எனக்கு இடமே இல்லை உங்களுக்கு போடுறதுக்கு அப்படின்னு தான் சொல்ற மாதிரி இருக்கும். So that is about the involvement of government. Being in the government sector, I have seen how much a pneumococcal conjugate vaccine will cost. It is 2,000 rupees. We are giving it free of cost for all these children at 6, 10, 14 weeks. Now we have even given a booster at 10 months of age. Then certain clues you should look at when you come across a child who has got fever. The pattern of fever, as you all know, if there is a wide variation in the temperature, sometimes it goes 103, then comes back to 99. That means you think of septicemia. That is a clue for you. If there is a wide fluctuation in the temperature, be careful, you could be dealing with a septic child. Because in young infants, you will not have the exact findings of sepsis. Always have the differential diagnosis of high-grade fever in young infants as septicemia. Then the pattern of fever, as you all know, nowadays we are going to see dengue. We have to get ready for the dengue season. It is always biphasic. So the mother will be happy at the end of 5 days. She'll say, then the tsunami is going to come later. So after 2 days, she'll come back to you and say, my child has become even more dull and he's got edema, he's got some skin lesions and all the stuff. So you should be careful of dealing with biphasic fevers. Tell the mother to watch. Tell her that if you suspect in dengue, probably the fever may come back or the child may become even more sick, and tell her that critical phase has to be expected in advance so that the mother does not miss these findings. Very high temperature above 105 or 106 degrees is usually non-infectious. You can remember this message, take home messages. It is non-infectious. It is probably because of the central nervous system or probably because of excessive heat, which we had in the last meal, which crossed 100 degrees of temperature, or very rarely malignant hyperthermia. That is only the reason of very, very high temperature. It is usually non-infectious. Biphasic pattern of fever for those post-virus who are here, dengue, leptospirosis, and enterovirus infections will present with biphasic pattern of fever. These are the 3 conditions which they present. Then coming to today's topic, the most common cause of fever is viral infection. So don't jump to write an antibiotic unless you feel it is essential for the particular child. If a child is less than 3 months, it's an infant, or if it's a newborn, you can take the risk of starting empirical antibiotics, but not for older children who can communicate well and the mother can identify the signs well. So less than 3 months, very high fever, be cautious. If you want, you can start an empirical antibiotic, but older children who are more than 1 year, don't jump and start antibiotics because viral infections are very common. And nowadays, enterovirus infections are become very, very common in your day-to-day practice. Every other day, you see a hand, foot, mouth disease child. There are about 5 or 6 children coming nowadays, even in a single day with the hand, foot, mouth disease. There is a huge epidemic which is going on now. And one thing mother will always say, but in the hand, foot, mouth only, it comes to twice or thrice also for the same patient. So you should be aware that it can recur. Like chickenpox and measles usually does not recur, but hand, foot, mouth disease will recur. Then one more important point of hand, foot, mouth disease for practitioners here is after 1 month, they will give you a history of the nails shedding. All the nails will go out from their fingers, and then again it will revert back, which is called mechanomedesis. So you should be aware that after 4 weeks of hand, foot, mouth disease, your nails will start shedding from the child's fingers. Then our role today is how do you detect seriousness? If a child has fever, how do you want to differentiate whether it is a sick child? Is it having a red flag sign? Do you want to intervene? Do you want to start antibiotics, or what are you going to do? That is what is our objective of this session. And if seriousness is ruled out, you don't have any red flag signs, please wait for 2 or 3 days. Tell the mother you can wait for another 2 or 3 days. It looks like just like a viral infection. It is going to settle down. You start antibiotics, the next day the fever becomes better. It is bacterial. You start antibiotics till the child continues to have fever. Don't go to the higher antibiotic within 24 hours. It is not going to serve the purpose. It is surely going to be a viral infection, which will settle by 4 or 5 days by itself. So abrupt cessation of fever following antibiotics, it is bacterial. If it is not responding, think that it is viral. It's a crowded slide. I'm sorry about this slide, but just I wanted to focus about Coxsackie A and Coxsackie B virus, which are very important organisms which causes hand, foot, mouth disease and your herpangina. Any child with high grade fever who comes to your hospital or clinic, the mother says there is drooling of saliva. If you don't look at the mouth, it's a sin. You have to open the mouth and look at the mouth because you will see a small ulcer at the pharynx. That is herpangina. You need not unnecessarily put these children on antibiotics. Otherwise, they will be on amoxicillin and clavulanic acid for 7 days. So just look at the mouth once. If the mother says not able to feed properly, that could be because of the lesions which is present inside. Both hand, foot, mouth disease and herpangina, the mother gives a history that my child is not able to feed and there is drooling of saliva. So you just watch out these signs in this particular patient. And acute hemorrhagic conjunctivitis is also caused by Coxsackie A virus. These three things are commonly caused by Coxsackie A. Coxsackie B virus causes myocarditis. So in a viral fever, if the child is very dull, lethargic, the pulses are feeble, the heart rate is invariably very high, it is not related to the temperature, it is more than the expected temperature, then you think of myocarditis. I used to tell my postgraduates, if there is a big heart, very high fever and arrhythmias, it is a triad for viral myocarditis. You have to be very careful, examine the pulses properly and see whether it is palpable or not. So that is about Coxsackie B virus. In addition, these enteroviruses can cause meningitis, meningoencephalitis. The most common virus which causes meningoencephalitis is enteroviruses. So this viral meningoencephalitis, in the past, we used to see JE, lot of Japanese encephalitis. Every casualty we used to do a CS lumbar puncture. Nowadays, the incidence of doing lumbar puncture itself has become very, very less because of the introduction of JE vaccine in Kadalur district and the neighboring districts. We don't see further case of JE. So now other viruses like enterovirus, especially the enterovirus 71, it causes a viral meningoencephalitis where the child comes to you with high grade fever. If you don't miss this neck rigidity or some other subtle signs of photophobia, next day the child will come back to you with the status epilepticus. So in these children, you have to be careful and look for these danger signs. At least if it's an infant, put your hand on the anterior fontanelle and see whether it is bulged, if the child is having a small neck rigidity, if it is not feeding well, irritability, headache is there. The child is having raised ICT, it cannot tell you I'm having raised ICT. What will it do? It will have headache. Even headache, it will not be able to communicate. So the only way it can communicate is irritability and crying continuously. So if a high grade fever child is crying continuously, one of the possibilities you should think of is a meningitis, especially if you are suspecting enterovirus infections. Then your echo or enterovirus can also cause encephalitis. So these are some important enteroviruses which are associated with short duration fevers and progresses to serious illnesses. That is why I'm focusing on this particular slide. This is just to give you a brief idea. The first one is, can you recollect? That is herpangina. So if you see these lesions, immediately please don't put the child on an antibiotic. It is an enteroviral viral infection caused by Coxsackie virus. Just reassurance, wait for some days, it will become better. Second one, it's already there. Third one, acute hemorrhagic conjunctivitis. So purulent conjunctivitis we always see every day. But if there is an hemorrhagic conjunctivitis, it is probably because of enterovirus. There you just have to wait again. See, you have a big heart here. So what complications the child develop? They have developed viral myocarditis. So if you have a suspicion, just do an X-ray, see for cardiomegaly, you'll be able to diagnose viral myocarditis because it's a dangerous condition. If you miss this child, the child may go for cardiogenic shock and the morbidity is higher. This is an old slide which was used in the past. Many of your seniors will be able to recollect this, but still I follow this particular pattern of teaching my students that this first, second, third, fourth, and fifth, sixth is any child with viral exanthem. These are all the 6 things that you should think of. If they have a rash, fever with maculopapular rash, because I'm in the government sector, it has to be notified. Even in the private practice, if you see a child with fever and maculopapular rash, it has to be notified. They are doing tests for measles and rubella. 2 things, they are doing a serology and telling you whether it is measles or rubella. But unfortunately or fortunately, we don't know. Many of these fever with rashes which we refer are not measles and rubella. So you should think of other conditions which can cause a fever with rash. So measles is the first disease. You all are very sure about measles. The exanthem will be a morbilliform rash. The enanthem will be a Koplik spot. Whatever is seen in the skin is an exanthem. Whatever is seen in the mucous membrane is an enanthem. That is measles. Second disease is scarlet fever. All these things are viral infection except scarlet fever. It is caused by a bacteria. So in that particular condition alone, you have to give an antibiotic. All other reasons, you need not start an antibiotic. Scarlet fever, you can remember all the SS. It is scarlet fever caused by streptococcus, sandpaper rash, strawberry tongue. These 4 things will be there. You just check the body. Mother சொல்லுவாங்க புல்ல அரிச்ச மாதிரி அப்படியே புள்ளியா இருக்குது உடம்பெல்லாம் loose flesh appearance இருக்கு அந்த மாதிரி இருந்துச்சு. You just look at the tongue. If they have a strawberry tongue, one of the differential diagnoses other than Kawasaki is scarlet fever. If they have a rash in the body, other 3 are all again viruses. Rubella is there. You know it is a 3-day measles. It causes a rash. How do you differentiate a rubella from a measles rash? The measles rash should be red in color, whereas the rubella rash will be pink in color. You have to observe the rash properly and you see how it presents in the rash. And the rubella rash should be more at the back. It will coalesce with each other together and it will be mild pink in color, whereas the measles rash will be red in color. And measles rash will have desquamation. Rubella rash will not have desquamation. These are all two important features which you can be able to differentiate measles from rubella. Then fifth disease is erythema infectiosum, where you have the classical slap cheeked appearance. We don't appreciate them because our complexion is on the brown side. In Western countries, they will put a lot of picture of slap cheek appearance. We don't see that because of our complexion. It is caused by parvovirus B19, which is caused a slap cheek appearance. Then roseola infantum, as you all know, fever disappears, rash appears. That is the classical take-home message to remember. Fever disappears. Mother will say, "Didina joram koranjichu." The odambala abbe pori pori rash vandiruchu. Again, it is pink in color. All the other rashes starts from the neck and the face and comes down like measles and rubella. Roseola alone starts from the trunk. That is the difference between measles, rubella, and roseola. So, if a child has a fever with rash, please think of all these conditions and localize your diagnosis and write in the prescription what you suspect. Then only then you will learn. Otherwise, you will not learn. So just know the organisms, parvovirus and human herpes virus. The first one is a morbilliform rash, maculopapular. What is that? The second one is a sandpaper rash, scarlet fever. The third one is a rose color rash, rubella. This is a slap cheek appearance. Disease number, fifth disease. Then you have a fever disappears, rash appears, which starts in the trunk and goes to the extremities. So this last one is out of the box. It's a white island in a Red Sea. So that is a classical rash of dengue. Now you're going to see the dengue season, which is going to come ahead to you. So you examine dengue children also for rash. One of the causes of fever with rash is dengue. The government says you please include dengue as a cause of fever with rash. So this is a second stage rash which comes in the recovery phase, not in the first phase. It comes in the recovery phase. It is a beautiful white island in a Red Sea. Then what do you do in a febrile child? Relax. If the child is playing, if the child is feeding well, it is active, it is doing whatever it wants, it passes urine normally. All these things are okay. Don't worry about anything. Just relax, ask the mother to take paracetamol. Some books are saying don't give paracetamol also, but in our practice, it's very difficult. Wait so sometimes we have to go towards the patient side and see if they have discomfort. If the child has fever and uncomfortable, please give them paracetamol. If the child is not is comfortable, you can at least reduce the dose of paracetamol. Mothers have the habit of giving 4 hours, 3 hours, second hourly paracetamol, and we land up with hepatotoxicity. Drowsiness, we think of meningitis, finally it will be paracetamol induced hepatotoxicity where the child will have encephalopathy. So please make sure, especially the drops, 1 ml drops which we give, they will just bombard it like anything because they want the child to be cold. Joram on the doctor to children the doctor sarila. That is the concept that they have. So you should try to explain them and tell them fever is a good response. Whatever you tell them, they will ask you the question. So that is a pattern that you are facing. So you try to spend some more time. Attention, young children, newborns, less than 3 months. Please don't take a risk. All older children, you are doing antibiotics and doing everything. Young children, you are saying, okay, they will land up with issues. Less than 3 months, postgraduates, please, if they have a very high fever, admit them. Less than 3 months, any child with high fever, do not send them home. Please admit them in the hospitals. And especially less than 1 month, newborns are known to have sepsis with hypothermia. Newborns will never have high-grade fever. If they have high-grade fever, it is CNS infection. So newborns are known to present with low temperature, not with high temperature. So if they come with high temperature, please take it very seriously. Underlying conditions, if they have a cerebral palsy, if they have a neurological disorder, if they have a diabetes mellitus, nowadays post-COVID, we are seeing many cases of diabetes. I'm not sure whether it is related to diabetes, type 1 diabetes. We saw a child 6 months, 1.5 years old. All these children have started to develop type 1 diabetes. So probably we have to think whether there is an immune reaction which is going on with them. Then unexplained death, mother will say, please give some more importance. No, they have lost a beautiful child in their family. So you have to give importance. Talk to the mother. If she's concerned, something is wrong, you will be wrong always. The mother will be always right. Don't think the mother is just blabbering something. Mother will tell you a beautiful history if you just have the patience to listen to her for 2 minutes. As soon as she says fever, no, we start examining. We don't even allow her to talk. If you just recollect, most of us, including me, within 30 seconds, we start examining the patient. Once they start the history, the time between their history and our examination is just 1 minute. Before that, we start examining. So please give them some time, especially children who have these red flag signs. So these are all the red flag signs. All of you are aware. I don't want you to bore with these things. Letharginess, drowsiness, altered sensorium. Child is vomiting continuously. It is not taking feeds well. High grade temperatures, disproportionate tachycardia. You all know 1 degree, 10 beats per minute can raise. But for one, the child is having 100 and the heart rate is 180. That means it is disproportionate. Something is wrong. Other than fever, there is some other pathophysiology which is going on. That is why I told you, you have to think of myocarditis. Whenever the child has a very high heart rate and the child has got a very high fever, please rule out myocarditis. Low urine output and rashes. Why I told you the rashes of all those conditions. Measles can have complications. Rubella can have complications. So examine for skin rashes. What must be noted? A single reading of temperature has no meaning. You have to monitor them serially. Some others are smart enough. They will give you a book. They'll have a paper. They will say, right, but she'll give you a beautiful history. These things are some important histories that you take. Serial record is mandatory. Trend of fever. How is the trend of fever? Response to antipyretics. That is more important. Even if you give paracetamol, there is no reduction of fever. Child is uncomfortable. You take it as a danger sign. It's a red flag sign. Interfebrile fever. All my professors used to say, it will give you a clue how the child's seriousness is. The child is lethargic, sleeping always throughout the day with fever. That is serious. In between fever, it is playful and active. It is not serious. Record the vitals. At least do a pulse oximeter. Most of the hospitals, private practitioners nowadays, we are seeing them sending with beautiful vitals recording, and then they send to us with saturations also. It gives a lot of help. You won't be thinking of a pneumonia. If you do the saturation, it will be 90%. Then you will take an X-ray. Then you will see there is a pneumonia inside. So the saturation will give you a clue that the lung is also involved. Head to foot. Do a proper and a rapid head to foot assessment. Young infants, put your hands on the anterior funnel layer. Check for ear infections, otitis media, pharyngitis. Then come down here, neck rigidity. Then you check for pneumonia. Auscultate the heart for myocarditis. Come to the abdomen, see if they have any organomegaly. Then come to the bladder, think of UTI. Then come to the hip joints, think of arthritis or any joint involvement. Then examine for the skin for rashes. This rapid assessment will give you whether a fever has got a serious sign or a normal sign. That is what you do, a head to foot examination rapidly. Then coming to the laboratory aspect, as sir was telling, a lot of point of care devices are available. You can immediately check for the antigen, whether it is a streptococcus or if it is a viral pharyngitis, and then you can start antibiotics. But in developed countries, they are doing that. In developing countries, we still do not have the privilege of checking all these patients. Instead, you have to use a clinical acumen. You can't rely too much on this rapid antigen detection test. So have a proper history, proper physical examination, do some important investigations like these investigations. And most common investigation for a fever child is just a complete blood count and a urine routine. Nowadays, CRP also can be done. Procalcitonin is supposed to be very specific for bacterial infection, but one procalcitonin will cost you 2,000 rupees. Many of the patients will not be willing to do this investigations. So CRP, procalcitonin, complete blood count, and the urine routine. I would just stick on with CBC and urine routine as a basic investigation and rely more on WBC count than the CRP. Many of the times the CRP has a false positive reaction. It's an acute phase reactant. Child does not sleep well yesterday. Suddenly the CRP is higher. Immediately you think it's a bacterial and a serious infection. So we have to be very careful, and it's a tricky investigation. So don't rely too much on CRP. This is my opinion. Probably others can differ. Then if the child has meningeal irritation or other headache, CSF has to be done. Take home messages, as I told you. Fever is a self-limiting illness. You just have to wait and watch. Fever is an adaptive response. It can be treated on special circumstances alone. Temperature increase in your body, it causes a decreased replication of the microbia. If there is a very high fever, the microbia will not multiply. So that itself works like an antibiotic for you, or an antipyretic. So the most common antibiotics are acetaminophen. You give 4 to 6 hours once. Ibuprofen also is authorized in developed countries and in our country also. Please do not use mefenamic acid. Even I have used it in my private practice, but for guidelines and evidence-based medicine, it should not be used for fever. It has got a lot of other side effects. Children can develop arthritis, they can come with a lot of joint pains and other things. So if you have a high fever, use ibuprofen, but just keep in mind whether you are treating dengue. If it's a dengue child, don't use ibuprofen. If you have even a small suspicion of dengue, don't start ibuprofen, just stick on with paracetamol. Sorry. No, అది close material. This line are clear. You go to last one for the before. Yeah. PowerPoint meeting. Statement. So what to do? Give proper hydration. We only concentrate on the fever. We tell the mother to give a lot of paracetamol, but we forget not to tell them about taking a lot of water. If you have very high fever, I have seen children, if you hydrate them properly, the fever comes down. Just paracetamol alone will not help them. Please hydrate them properly. Give proper rest and tepid sponging. Some school of thought is don't use tepid sponging. Some schools say you can use tepid sponging. But what we have seen is when the fever is very high and you want it to bring it down immediately, you can do tepid sponging, but not as a routine process. What not to do not overdress the child. The mother will pack them with a lot of things saying that the fever will become better if you give a lot of clothes. Do not sponge with cold water. They have the habit of using cold water. Avoid NSAIDs and do not send them to school. That is the most important advice you please give them. It is going to spread to the other children and also make the child more lethargic. So please tell them don't not to send them to school. These are all some serious bacterial infections in a short duration fever. Think of UTI, meningitis, septicemia, pneumonia, and septic arthritis. These are all some serious infections. There are some criteria available for postgraduates like Boston criteria and Philadelphia criteria, which my colleague Dr. Delhi Kumar may be explaining to you. So you should be thinking of these serious infections. Should I give antibiotics in viral infections? It is not warranted. Look at the accompanying symptoms. If you feel it is a bacterial infection, you give antibiotics. Bacterial infections are always localized. Viral infections are generalized. So if the child has many systemic involvement, it is viral. If the child has a single system involvement, it is mostly bacterial. If it's a pneumonia, it's bacterial. It's a single system. If they have joint pain, rashes, oral ulcers, everything together, it is probably viral. So generalized and localized. Antimicrobial resistance already in the first, at the beginning itself, I told you, it is a emerging problem for all of us. So please let us all join together and help the country to avoid these high resistant organisms. Nowadays, we are getting carbapenem resistant enterobacteria. Even your meropenem is not working for many of the children, and they are only working for colistin and polymyxin. So we have gone to that end. We don't have anything else more than that. We are going to the dead end now. So you look at ABC, arousal, breathing, how's the color, how's the child taking fluid, look at activity, stabilize the child, treat the patient and not the number. Don't treat 103 or 104. Please look at the child and treat that particular child. Paracetamol can be given for comfort. Let the disease evolve. Every fever case is not always an indication of antibiotic prescription. Day 1, you will have only fever. Day 2, probably if you look at the mouth, they will have a small ulcer. So wait for it to evolve. It will give you some signs. Don't think first day itself fever without focus. Monday, ask them to review after 1 or 2 days, you will get the signs. Thank you very much.
Thank you very much, Professor Ramnathan. And it reminded me of 2 textbooks of clinical methods, which we had read those days, Hutchison and Papworth. And I think I was reminded of, it was probably Papworth himself coming and presenting the important things, because people hardly look at the clinical methods, because the patient come to you first to be listened to, then to be examined, and then only to be investigated. It is just not the ulta-pulta. It is just not the other way. And I think you have very clearly said that antibiotics should not be used as antipyretics. And I think that is a very important point which you had said, and especially about the antimicrobial resistance. அடுத்த ஜெனரேஷனுக்கு நீங்க என்ன சொத்தை கொடுத்துட்டு போறீங்க? Are you going to give them hand over a baton with a lot of resistant bacteria, or are you going to give them a very safe environment? And I think that point also you beautifully brought up, sir. Thank you very much for it. And now I request Professor Delhi Kumar to go ahead with certain criteria which he had very nicely listed in his preparation. Thank you, Dr. Delhi.
Good afternoon, everyone. I thank organizer for giving me the opportunity. Professor Ramanathan, he already covered most of things. So for me, the job is already over. So we will focus mainly on baby coming with a fever. So what are the things we generally look step by step approach. So first, any baby coming with fever, what we generally see. Anybody can answer. So first, what we see is coming with fever 2 days, 3 days duration, any infant or older children. First, we try to find out what is the cause for the fever. So most of the time, our simple history, no, that will give clue. So okay, most of the time, no, simple history will give the clue. These are the most common focus we generally observe in our clinical practice, which already been well covered. So by simple history, like often cold, vomiting, diarrhea, loose stools, body micturition. So if we have focus, it is very easy. So treat according to the focus. So what is the diagnosis? It may be URI, maybe acute diarrhea, or it may be UTI. So it, based on the focus, we can manage the patient. So where is the problem? So there are many causes for fever. So these are the commonly observed focus: crude bronchiolitis, otitis media, gastroenteritis. So better to be aware about the uncommon causes also, like drug fever, Kawasaki disease, and other leukemia and rheumatic condition. These are all will come under the long duration fever. Recently also we had 2 infant we admitted with the fever. One baby was having more than 2 weeks fever. So already OPD basis child was evaluated. They have done CBC, RFT, LFT, and the procalcitonin, CRP, everything was normal. When child was admitted for further evaluation, so mother gave the diagnosis. So we are asking, everything was normal, child also looking well. Then mother told me, after coming to the hospital, my child is better, feeding well, passing urine well. But in the home, child is not all right. So child is not feeding, decreased urine output, their fever is there. Then the diagnosis was because of the summer, no? Their house was very hot. That's a cemented roof, and the child is having dehydration fever. So that was the clue mother gave. Immediately after coming to the hospital, no fever resolved. We did nothing. We just observed 2 days in the air conditioned room. Child did not have further fever, so we discharged the patient. So that simple clue by the mother itself gave the diagnosis. The next week also we had the infant with a similar condition. Many times newborn can have dehydration fever, but this summer we observed infant with the dehydration fever. So we did nothing. So most of the infant are well looking, they resolved and they went home. So the first step is whenever any baby coming with fever, look for any focus. If you are able to identify the focus, treat according to the focus. So the problem comes when we don't have the focus. So we did a clear thorough history and physical examination. Still, we are not able to find out any focus in 3 months to 3-year-old child with less than 7 days duration. That we label it as a fever without focus. Most of the baby fever without focus also is a viral fever. They have good prognosis. It resolves spontaneously. What we are worried about is missing the serious bacterial infection. That is possible in 1 to 30% of the baby with fever without focus. So we will at risk for the serious bacterial infection when baby is not having the focus. So age less than 3 months. So under those who are appearing sick and anybody is having underlying comorbid illnesses, any chronic illnesses, fever without focus, be cautious. That may be a serious bacterial infection. Of course, immunocompromised children. So anybody is on chemotherapy, on steroid, coming fever without focus, we always consider that child may be having the serious bacterial infection. We admit and start the antibiotic immediately. So what are the common differential diagnosis of fever without focus? So the most common thing is urinary tract infection. So even child did not give, or mother did not give history of any urinary symptoms, it is still possible that that baby having the urinary tract infection. In 8 to 10% of the children with fever without focus, no, there is a possibility of urinary tract infection. The other thing we are worried about is occult bacteremia. So occult bacteremia pre-pneumococcal vaccine era, it was 3 to 11%. Now it was significantly reduced to less than 1%. So this is important, whether baby is fully immunized or not. Fully immunized children, possibility of occult bacteremia is very less. So that history also we should carefully take in the while assessing the child. The other possibility is occult pneumonia. See, most of the time we will be able to diagnose the pneumonia. So they have tachypnea, cough and cold, respiratory distress. Sometimes with the small baby, physical examination may not be possible. That time, there is a possibility that we may be missing the occult pneumonia, especially if CBC you have done, it shows more than 20,000 total WBC count, consider the possibility of occult pneumonia. So the rare possibility like septic arthritis, osteomyelitis also we should keep in our mind when assessing a baby with fever without any focus. Especially baby limb one side is not moving or any joint movement is very painful. That may be a case of septic arthritis or osteomyelitis that we need to be carefully evaluate. History of immunization we should always take whenever child is presenting with the fever. So that may be due to post-vaccine fever. So these are the possibility we should keep in our mind whenever we are evaluating a baby with fever without any focus. So what are the important approach for a baby with a focus? So first we have to revisit our history. So whenever mother is telling child is having fever, first you document the fever. Many times they will tell fever is there, but when we observe the child and document the fever temperature, no, it will be normal. So they may be having misperception about the fever. So first you document when a child is having any fever. First we need to document in the hospital. Then assess for the child functional status. So you assess whether feeding, activity of the child, and whether sensorium, how's the sensorium, irritability, lethargy, all these things we need to assess. As I already mentioned, no, look for the limb movement that will give a history. Of course, immunization and immunodeficiency you should carefully assess. If that is the risk of serious bacterial infection is very high. So this Ramanathan Sarma, he already clearly mentioned about all these images. So these are the hidden focus which we need to examine, which he has already mentioned in his presentation. So this is about definition of tachypnea and tachycardia in the children. So less than 1 year, more than 160, 1 to 2 year, more than 150, and 2 to 5 year, 140. This we all know. Up to 5 months, 60, and up to 1 year, 50, more than 1 year, 40 is the respiratory rate cutoff value. So there is a National Institute of Health and Care Excellence guideline is there to approach the children with the fever. So this is the traffic light system. Like what they are divided into 3 categories. Any baby with the fever. So amber, green, and red. Red is a high risk group. So it is like same assessment. Our clinical assessment, they have given a structured format. So first we have to look at the color. So any pale or blue color is a high risk children. So paler reported by the caregiver is a intermediate risk. So this green side is the normal children. So normal color, everything. So the other activity you have to see, the high risk is so no response to social cues and appears ill for the healthcare professional and does not awake. Even if awake, does not stay awake for some time. So weak and high pitched cry or continuous cry. These things considered as a high risk baby, any children with the fever. So intermediate risk is child is having decreased activity, no smile, not normally responding to the social cues. wakes only with the prolonged stimulation. No, they consider as a intermediate risk. Then you have to go assess the respiratory system. So any grunting, tachypnea, and retractions considered as a high risk babies. Only nasal flaring, tachypnea, reduced saturation considered as an intermediate risk. So assessment of circulation and hydration. So decreased skin turgidity is a high risk group, and tachycardia, prolonged CRT, poor feeding, dry mucous membrane, reduced urine output considered as an intermediate risk. Other factors to consider to classify them is age less than 3 months is always high risk. So any child with bulging fontanelle, neck stiffness, status epilepticus, focal neuralgic signs, focal seizures, consider them as a high risk population. Intermediate risk is 3 to 6 months age with fever and rigor, any swelling in the limbs and not bearing the weight. These are the babies considered as an intermediate risk for the classification by the NICE guidelines. So what are all the investigation to do? Fever without focus. Do we need to investigate? So commonly what investigation we do is only WBC count, ANC. If facility is there, we can go for procalcitonin. Procalcitonin, they consider it's the most cost effective to diagnose the serious bacterial infection. More than 0.5 nanogram per ml, no, they consider as a sensitivity of 82%, specificity of 86% to diagnose the invasive bacterial infection in babies without any focus. Chest X-ray, only sick-looking child, if WBC count is more than 20,000, we can consider if there is no proof by clinical examination. Otherwise, not required routinely. So, most of these children without focus, we need to do urine routine examination. So, we can do only dipstick test, leukocyte esterase, and urine nitrate you can assess. If both are positive, possibility of UTI is 2 to 6%. So any one test is positive, possibility of UTI is 40 to 65%. Both tests are positive. Leukocyte esterase and nitrate positive is possibility is 75 to 90%. So these are the according to the NICE traffic light system. No, what are the investigation to do in the high risk group and low risk group and intermediate risk group? So high risk group, what are the investigation we do? CBC, blood culture, CRP, procalcitonin, and urine dipstick test, lumbar punctures, chest X-ray, serum electrolyte, and blood gas. Anybody with the low risk group, no need for any testing except maybe urine routine. Other than that, blood test is not required in a low risk children. So in intermediate risk group, we can do CBC, blood culture, CRP or procalcitonin, and urine testing. Chest X-ray, we can consider only when WBC count is more than 20,000. Lumbar puncture, we can consider in a less than 1 year old child in the intermediate risk. So apart from NICE guidelines, there are other guidelines also to identify the serious bacterial infection in a child with the fever without any focus. This is a young infant observation scale for less than 3 months. If you see, most of them are using the same criteria: respiratory distress and skin perfusion and general condition, cry activity. So this score more than less than 7 is low risk, more than 7 is high risk of the serious bacterial infection. So this is the another criteria used before the NICE guidelines has come out. It's a Rochester criteria. It is less than 2-month-old child. If all these things are there, then they consider as a low risk population for the bacterial infection. So term baby, no hospitalization, no prior antibiotic, no jaundice, no underlying disease, no skeletal toxicity, ear infection. And this criteria includes the blood counts also. So WBC count 5 to 15,000, band cell count less than 500, and leukocyte less than 5 if diarrhea is there, and the urine count is less than 10, they consider as a low risk for the serious bacterial infection. This is also another criteria used for 3 months to 36-month-old children. So this is also almost similar to NICE guidelines, so we are not going in detail. So we'll discuss about how to approach a child without fever, without any focus. So first thing is you have to see the age of the child. Less than 3 months, possibility of serious bacterial infection is very high. So always do screening tests. If child is having less than 3 months of age, even if child is well looking, you have to screen because the possibility of serious infection is very high in this group. So if focus is there, treat according to focus. If no focus is there, always do this urine microscopy, CBC, blood culture, and the CRP. If anything is positive, treat with the systemic antibiotic. If anything is positive treated systemic antibiotic. If everything is negative, you can observe the child closely till fever resolves or if any other focus child develops. So similarly, so if child is appearing sick, there is no question. Straight away you admit and start take all investigation and treat with the antibiotic for less than 3 months old child. More than 3 month old child, if child is appearing well, so you can wait and watch. You can do only urine routine and see whether it is positive or not. So if it is negative, just wait child. If child is not appearing well, then you investigate and admit and start antibiotic. So red flag signs already discussed by the Ramanathan sir. So we are not all these things also already discussed. So tepid sponging, he has already mentioned. So one thing is respond to antibiotics, no, we should not take it to differentiate bacterial from the virus infection. So that concept should not be there. And whether degree of fever will give clue whether it is a bacteria or virus. So sometimes yes, more than 104 bacterial infection possibility is very high. So 102 to 104 we cannot differentiate in maybe bacterial or viral. So we are which temperature to take. So whichever is convenient. So we are routinely doing actual temperature. One is no need to do always rectal temperature. That's not required for the routine practice. So oral antibiotic also not required for the fever without focus in the children. So urine specimen better to take catheterized sample or clean mid-catch urine which child is toilet trained. So collecting the urine from the bag no, is not recommended. So the take-home message is, so first any infant coming with fever, look for the focus. If focus is there, treat according to that. If there is no focus, do detailed history and examination and try to identify any hidden focus is there. Still, if you are not able to identify the focus, less than 3 month old child, you always investigate and see the screening test system. Based on that, you take a decision. More than 3 month old child, if child is well looking, you do only urine routine. More than that, not required. If child is not well looking, you do screening test and blood culture, admit and give IV antibiotic. So whenever you are observing the child, the proper counseling is required. You have to carefully monitor the child for the resolution of the fever or appearance of the new symptoms. So with this, I thank everyone for listening to me patiently. This fever with rash is already covered by the Ramanathan sir, so we are not discussing it in detail. So these are the some patient we had in our hospital with the chikungunya, and he had a different types of rash. So this is the study done in our center. No, it showed chikungunya will have different types of rash, not only the any type of rash can come. Erythematous macula, hyperpigmentation, disformation, glandular bullous dermatosis. So this was bullous lesion, disformation, and this is the hyperpigmentation with the disformation child. So these are the rashes we observed in the chikungunya, apart from the rashes discussed by the Ramanathan. So this is not for this presentation. This is the one rare case we observed in our hospital. This is a cutaneous anthrax with the H2. Thank you.
So, thank you very much, Mr. Dilli Kumar. I think there's been a very illustrative and a very organized approach to the thing you had now gone to the next level. Now, what was purely clinical, why should Dr. Dilli Kumar go on to criteria? Now, we are in a society which is a litigant society, that is number one. For everything, they ask for proof. And even if they go to the court, the judge will ask, so for that, the building up of criteria by professional bodies have become a common way of life now. That is number one. Number two, insurance companies. Nowadays, more than the doctors deciding about the treatment, it is the insurance company which decide about the treatment. And for insurance company, they have very set criteria based on which they will say, they will give authorization. Okay, we authorize, then you can give this medicine. So for that also, these criteria, they have taken from what has been practiced elsewhere, and then they have got. So we have to graduate more from just clinical to certain criteria which are both clinical as well as this thing. So I think in that way, I think all the criteria, and especially the NICE criteria, is very well illustrated. So now I'm going to summarize with just some parting thoughts. Number one is, ஜுரம் 2-3 நாளைக்கு இருந்ததுங்க, அது அப்படியே சரியா போயிடுச்சு. And what the mother says, her observations have to be respected. Not that any observation which only comes from teaching institutions or ivory towers should be looked at, because the mother is basically the first ivory tower. So the fever, I would call it as the fire of life. And then I will take you through these thoughts before I conclude. In fact, this is recent research which has been done in the University of Alberta, Canada. Though this has been done in the life sciences group, it doesn't mean that even in drug trials, what we do is we go through various phases in which we go from the animals to the human beings. So in that way, though this has been done in fish and other things, it doesn't mean life is one. The life principle is one. And this will be applicable to the human beings also. Fever integrates antimicrobial defenses, inflammation control, and tissue repair in a cold-blooded vertebrate. Fever may clear infection in about 7 days. That is, if you give rest. That rest itself is a process which allows the fever to shut down the inflammation and repair the injured tissues. And I think Professor Ramanathan got it out in the early part of his lecture on this important point. And number two, moderate fever is usually self-resolving. Body can both induce it and shut it down naturally without medication. Better to let a mild fever run its course instead of auto mode, immediately don't switch it off to paracetamol QID. Because I'm telling you, in intensive care unit, when you say sometimes cases which come with an unexplained sort of a liver failure, the thing was paracetamol tox. Paracetamol sambar. So that is how they land up with this thing. So remember that for fever, you need to give certain things, but at the same time, you think there is no safe drug in here. There are only safe doctors. So in that way, I think fever as the fire of life has to be looked at very carefully. Number two, this is what is called, I think Professor Ramanathan said about viral infections tend to spread. Yes, red eyes, red ears, red throat, red skin, and sometimes if these children die, whom we have seen in those days in post-measles, even the trachea will be red. So viral infections tend to spread, whereas bacterial infections tend to localize. Acute otitis media, suppurative or follicular tonsillitis, a lobar pneumonia, and an abscess which is pointing. So bacterial infections tend to localize. And I think students always may not remember this virus or bacteria, but suppose you give one name, then they will immediately remember. And this is called Lightwood's law. This Lightwood's law was described as early as 1960 in clinical methods, which tells about the viral infections tending to spread and bacterial infections tending to. This I'm reiterating what Professor Ramanathan again said, that this is an important clue. The important thing is we must learn to see. Doctors know many things. I don't say doctors do not need. Amma vandu sonna odana enna unakku romba theriyuma naanga paakliya. I mean, that is our knee-jerk reaction to any mother who is trying to tell us one more point in the history. They hesitate a lot. நம்ம மூஞ்சியை பார்த்துட்டு வாயை திறக்கலாமா திறக்கக்கூடாதுன்னு ஒரு மாதிரி ஒரு பயத்தோட சொல்லுவாங்க. அப்போ வந்து at that particular point, a criticized child becomes an inhibited child. Let it be a child or let it be an adult. The moment they don't understand your tonal language, they understand your body language. The moment நீங்க கண்ணை இப்படி சுருக்கின உடனே அந்த அம்மா சொல்றது நிறுத்து. So remember that sometimes, as you also brought up the same point, which I want to again emphasize, smart mothers make sometimes better diagnosis than doctors who are just coming up. Because doctors know many things, but they do not see enough. So I think this is an important point. The mother is always right unless proved otherwise. And on this, I think this is important. We must know our limitations. By telling I do not know, it doesn't mean that we are trying to, other person will look at us. They are very happy that you are sincere about yourself. I do not know my limitations. And at the same time, this will help you to look for an answer. Where is the answer? And I think this is the culture which I think the postgraduates should probably, if you think it is useful, take it. Otherwise, you don't have to. Because the speaker will be here today, he will disappear from the scene some other day. But it is your life and it is your journey. So remember that Lightwood's law, as well as the mother's thing, is very important. Yes. I'm getting humorous. So I think as far as we've gone through in colleges, a college is a place where a professor's lecture notes go straight into the students' lecture notes without passing through the brain of either. But attributed to Mark Twain, but maybe it is a sort of this thing about it, the authenticity of it may be questioned, but still I think this is a very well-known quote from Mark Twain. So remember that lectures are necessary to get you focus, but your lecture notes, your textbooks in the library are nothing but the patients who come to you daily. Look at them. They are your textbooks. Then after looking at them, learning from them, go back to the textbooks and verify what you have seen is right or wrong. And if it is not right, question, ask the teacher, sir, unless you say, I am hungry, I want idli, your mother will not know what to cook for you. Similarly, the same thing, unless you tell, I do not know, the answer cannot come to you. Not that you see, Maunam Sarvanta Sadhakam, no. Sometimes silence is golden, no doubt. But at the same time, when it comes to learning, you need to be inquisitive. You need to always keep asking, because learning is a death-long discipline. Nothing can be taught. Everything has to be learned. And of course, about the risk factors, which I think, sir, both of them talked about risk factors. I will only look at this thing. This child, I know pretty well that this child must be having a whooping cough. And also he is malnourished. Maybe he's also having an adenoid because his tongue, half mouth breathing. And they would have gone around that kind of a shopping for around 2 weeks before they land up in hospital like this. And I think a child who comes with a mild fever, but with a look like that, you know pretty well that this is a malnourished child who is at a risk for progression. And of course, this child, but basically, this is nothing but a child who had been on steroid drops. For one fever, they had given steroids. The child took, and then, when evening, when there is a sharing of talk between the housewives, they say, so what happens is this child was more or less, this child was taking steroid drops daily, and now this child will come, and suddenly you will find these children go down the hill because you know that steroid is a immunosuppressant. Every newborn is like a cancer patient. Their immune system is just developing. And all these grown children are again at a risk for serious bacterial infection because they may be on steroids. So that history and looking at this, so the looks may be deceptive. Mistrust the obvious. So looks may be deceptive. So these are the risk factors for progression. Yes, this child came in a shock. You can see that an intraosseous infusion has been given for this child. And at the same time, you had the phase 2. I think Dr. Balasubramanian, if you are here, I have heard his yearly lectures on dengue. He used to say, tomato palm and tomato souls. He used to say, he used to describe that and this was nothing but a child who came with a dengue shock. And I think, I'm sorry, sir, you have warned us that dengue is coming up. They wish that children should come to the hospital only for immunization and wish they don't come for infection. This is another important thing. What Corona has brought us, two important things. It brought us the importance of computer science. Corona brought us the importance of microbiology. But at the same time, it also brought us another culture that every child who comes sick, do a pulse oximeter. And in dengue, one important thing came up was taking blood pressure and doing the hematocrit. And I think these two are very landmark papers which came on hematocrit from the Indians. And I think Professor Balasubramanian's paper from Journal of Tropical Pediatrics, this just defines the hematocrit values against the anemia, because anemia is a common denominator in all our children. And I think these two papers have to be looked at for the standard hematocrit value here, because in dengue being a distributive shock, we always look for hematocrit. So fever, BP, and hematocrit is another important clinical finding which we should never miss. I think in the rounds or in your immediately post-admission rounds, if your resident has not done this, I think they are to be asked to get it. It's all, what's the question of small habit? Today, let them do. They are not doing over that 1 week, let them keep on telling about it. And this is what is called habit stacking. They will come every day, keep everything ready. One more habit, keep insisting on that another for 2 weeks. That habit will get stagnant and your system will improve. Actually, success is not reaching a goal. Success is refining a system. So and I think fever, BP, hematocrit has now come to stay, especially after dengue. simulation education. So I think now with the non-availability of papers, I mean, many patients, and at the same time, we have a lot of medical colleges coming up. I think simulation education is something to be done. And I think when I was talking to Dr. Mishra in the morning now, I think they said that there are some institutions in the capital which has excelling in simulation education. So it is like Padam Bharati Kadaisol is PowerPoint. Whereas Senji Parthi Konjam, to get the hang of it, I think simulation education is going to come and stay there. And I think you should, for this particular lecture, I think our panel had gone through these things, especially the nice National Institute for Health and Care, especially the RAG, that is red, amber, and green traffic light system for assessment, which Professor Dendy Kumar so nicely brought it out. And the important guidelines which Dr. Balasubramanian had, I mean, Dr. Ramanathan has said, and these are the suggested reading which is available. So I think now, end of it, I'm going to thank you all again for your time and patience, because the IAP legacy cannot just go away like that, because this is one of the very strong bodies. And it is as strong as this kind of a structure, a Buddhist structure in, I think, Sanchi, Madhya Pradesh. Our legacy is very strong, especially for a continuing academic education. And for skill-based workshop, which I think Tamil Nadu chapter has organized time and again, and you are proving yourself well. Thank you.
Thank you, sir. And it's Dr. V. Namashivai to felicitate Dr. S. Mahadev. It's Dr. Balasubramanian to felicitate Dr. Dendy Kumar. And it's Dr. Balam Kumar to felicitate Dr. Ramanathan. Dr. Sautarajan will felicitate Dr. Ramanathan.
I'm going to say this one.
We have our next panel discussion on day-to-day problems in primary and secondary neonatal care. Our moderator will be Dr. Tirumurugan Seran. Our panelists, Dr. B. Adishivam, Dr. N. Chandrakumar, and Dr. K. Karthikeyan.
நீங்க நல்ல சாப்பாடு போட்டோம்னு நினைக்கிறோம். போட்டோமா? Thank you. So அதனால கொஞ்சம் தூங்காம இருக்கிறதுக்காக we'll make it more interactive session rather than as a pure discussion where we talk and then you guys sit down and so with that in mind, I'm really honored to be here. I think honor is often a word which is very loosely used, isn't it? And still, it has still got a lot of meaning. I'm honored here because we have 3 people whom I can say are younger than me and still better than me. We have Professor Radhi Sivam, who is of course, my junior from JIPMA, and sorry, that's me. Oh. Sorry. Who has done a tremendous work in the Department of Neonatology and who has established the neonatology, the Human Milk Bank. And of course, in the circles of IAP, Pondicherry and Pondicherry Pediatric Forum, we all know him as a very good poet. வாரத்துல 2 தடவையாவது அவரோட நல்ல அழகான கவிதையை பார்க்கலாம் நமக்கு தூக்கமே வராது கரெக்டா அதனால அவர் கரெக்டா எழுதிடுவார் அட்லீஸ்ட் அண்ட் அப்கோர்ஸ் இட்ஸ் இங்கிலீஷ் டிரான்ஸ்லேஷன் வித் டாக்டர் வெங்கடேஷ் and Dr. Chandra Kumar, another product of JIPMA, who is currently the HOD of neonatology from Child Trust, and of course Dr. Karthikeyan, who has done a fantastic work with the neonatal unit in MGMC. So 3 really good speakers. So we thought we will talk something which is very practical, relevant. Neonatology in general, what happens is it becomes a very hardcore stuff, isn't it? Can we just turn off some of the slides? Couple of the slides. So it is something which has been kind of isolated to people who are working in the hospitals. Whereas the truth is, in practice, we do see a lot of cases of neonatology. And in fact, majority of the problems which we encounter in a NICU or beyond has its origins in the private care, in the peripheral primary care. So let us think about this first scenario. Of course, before Dr. Chandra Kumar, I want inputs from the audience. We have had a primary gravida mother at 38 weeks who was born, birth weight was 3.2 kg. She was bent upon breastfeeding and she had gone home breastfeeding and brings the child back on day 5 with fever and irritability. What do you think would be possible causes? What other details would you need for a diagnostic group before I go on to the panelists? Okay, current weight of the child is 1. Yes, fantastic. Feed adequacy on feeding. Urine output. I think we don't need this panel. So, but anyway, I think having had Dr. Chandra Kumar, I think I'll pass it on to Chandra.
This is what in that line only we should be thinking. Okay. So first and foremost question we should ask is current weight of the baby. To know whether baby is thriving well, baby is losing only the normal amount of weight loss which is expected. Amount of weight loss which is expected, or baby has lost excessive weight. So current weight of the baby is very important. Then about a lot of more details about feeding history, including frequency of breastfeeding, whether it is adequate, nature and frequency of stools, which is important. Okay, transitional stools. If baby is already 5 days old and baby is, the stool color is not changing, it is still meconium kind of greenish black in consistency, then it sounds an alarm. Okay, feeding may not be going on well. And that nature and frequency of stools, all of you know, baby should be passing at least 2 to 3 times stools. Frequency of urination at least 6 to 8 times per day. All these things would ensure whether his feeding is going on adequately or not, and whether any pre-lactate feeds or anything is given, because which may be a source of infection. And along with this, you should also ask for other symptoms like lethargy, seizures in the baby, discharge from umbilicus, pustules, baby not moving one side for any limb in particular. This may be focus of infection. Okay, but what is foremost important is current weight and then it will related to feedings.
Okay, so thank you. So what do you think is possible? What are the diagnostic possibilities in such a child? Day 5, fever, not feeding great. What are the possibilities? Okay, somebody thinks of dehydration, fine. most obvious. Sometimes we still keep looking for the zebra. So let us start looking for the horses. Sepsis, yes, that is the first thing we should think about. Inigo, I think what we need to remember is sepsis is the diagnosis which we need to always think in a newborn. As the last session was told, it's basically something like a cancer patient in waiting for getting infected in any newborn. So always think of sepsis. Then, of course, dehydration. And then comes always a problem of inadequate feeding by itself. And then there are some very rare causes which you can think about. Let's not given the time scenario, I'm just going to rush through some of those. So just okay. So we have just moved on to examining the child. The child is irritable. The peripheries are warm. That tells me something. Okay. And then this child had a weight loss of about 400 grams and he's got jaundice up to icteric. So up to the legs. Now, how would you proceed, Dr. Chandrakumar?
I can go to the.
Yeah. Yeah.
This is important, like, whether you are looking at examining a baby who is febrile, and you should always concentrate on the peripheries of the baby, like how warm or cold they are. Okay. A baby with dehydration fever will always have warm peripheries. Okay. So a baby with fever due to infection, some form of sepsis, often tend to have cold peripheries. Okay. So that is an important point in clinical examination, which always you have to look for. And then how much percentage weight loss a baby has lost. Okay, that is important. Whether it is more than what is normal for that baby. So anything more than 10% beyond 5 days is considered, excessive weight loss. So then, like, few differentials clinically, certain things which may help us differentiate between what is dehydration and what is sepsis is, fever is almost always present in dehydration. In sepsis, fever may be there, may not be there. Okay, so most of the newborns with sepsis may not have fever. In fact, they may present with hypothermia instead. So weight loss is there, like weight loss is common, and it is more. In sepsis, weight loss may or may not be there. Peripheries are warm in dehydrated baby, but cold in sepsis. Pulses are well felt in dehydration. Pulses may be weak if they present in septic shock. But if they are in compensated phase, it may be good volume pulses in sepsis also. Activity dehydrated baby is often irritable. They would feed and then cry, they keep on crying. So a baby with sepsis is often lethargic. And when you take a laboratory, serum sodium is often elevated in babies with serum dehydration. It may be in the normal range in baby with sepsis. So by look of it, a dehydrated baby would look like this with a poor skin tone and darkness. A septic baby would be lethargic.
Okay, so to put it very simply, the child is going to stare at you and then scream. Think of fever, dehydration, and poor feeding issue. If it's a child who's just not bothered whether you're there, just close the eyes and just lying down. Think more in terms of a child who has got an infection. So the investigation, what investigation would you like to do, Doctor?
So whenever you come across a clinical scenario like this, so at least the baseline things will be like to check CBC, that is complete blood count, CRP, and serum sodium. Okay, so and bilirubin also, because all in dehydrated babies often tend to have jaundice as well. So this is the picture for our case. So total leukocyte count is 8,000, which is in the normal range for newborns. What is significant is in newborn is the leukopenia. If total leukocyte count less than 5,000 is more suggestive of sepsis than high elevated leukocyte count. And then absolute neutrophil count less than 1,800 is significant in newborns. Platelet count may be normal in sepsis, it may be reduced as well. CRP less than 6 milligram is normal, it is not suggestive of sepsis. Total serum bilirubin 13 in this baby is bit high, but still not in the phototherapy range. But serum sodium is going to give us an important clue. It is in the high normal side. Okay. So weight loss with serum sodium on the higher side is almost kind of suggestive of dehydration fever.
Okay, thank you. So from the audience, what do you think is going on based on these results? If this is what we got at the end of it, what do you think is the diagnosis? Okay, so we are fairly certain it's dehydration fever. Okay. So So now that brings us to the question, Dr. Adi, can I just ask you about what are the reasons why a baby might lose weight? Why is it that weight loss is such a big phenomenon in a newborn?
The big is the body surface area and the volume which is required. When compared to adults, the body surface area is. So even a small amount of volume loss is a big thing for maintaining the circulation. That is why we expect them to regain the birth weight earlier. Though initial weight loss is acceptable, as Dr. Chandrakumar said, more than 10% weight loss after 5 days is not significant. Is significant. So we need to we need to be very careful in assessing the weight of the child and the comfort follow-up and look into the feeding issues.
Thank you. So Dr. Chandra, back to Dr. Chandra. So why is it that summer is always a bit of a problem for these kind of babies? And we do see a lot of these babies during summer.
We see a lot of these babies in summer, especially in our part of the country. Why? Because there is high ambient temperature. And if the baby is, is smallish baby, and then doctor would have advised that baby should be covered well. Okay, in addition to feeding, baby should be covered well, they should not be exposed. But what happens is like mothers, they are too much apprehensive about baby becoming cold. They tend to wrap the baby well. During summer also when the ambient heat is so high. So then they also sweat and lose a lot of water. Okay, that is important. In addition to less feeding, they sweat and lose a lot of water. These two things combine and cause more of dehydration. And then obviously during summer, mother herself, may be dehydrated. So there are a lot of breastfeeding issues. She may not secrete adequate amount of milk. All these things contribute to dehydration in the milk.
Thank you. So either we cook them or we roast them, but the bottom line is baby loses a lot of weight. Covering too much or not covering it, both of them are not just good. Okay, so how to feed them?
So I think we have to, when it comes to addressing feeding issues, we have to stick to the basics. We have to ensure that, proper positioning and attachment of babies are ensured. I think we may not go through each and everything. Yeah.
Okay, so just to put it across, couple of points to remember. One is when you are feeding the baby, whatever position which is comfortable for the mother. Don't force the mother to feed in just one day sitting up position. See, I think most mothers here, mostly every mother here would know that after having delivered a baby, it is impossible to sit all the time upright and then try to give breastfeeding. Just imagine the mother doing that. So it's very difficult. So whatever position which is comfortable is the best position for breastfeeding, because that's one thing we need to remember. And always the second point to remember is that when you're feeding the baby, it's always baby to the breast and not the breast to the baby. And it's always again the upper lip should be touching the nipple. Those are the 2 points you need to tell the mother. If you can tell those 2 points, I think the mothers will understand. I think given the want of time, I'm just going to skip all that. So when would you admit such a child?
So babies with mild dehydration, if serum sodium levels are in the normal range, we can manage on OP basis. But risk a lot more than 50%. If serum sodium is more than 145, and if you strongly think that there could be risk of concurrent sepsis, then you have to admit breastfeeding.
So thank you. So that's pretty much it. So just to summarize about this kit. So day 5, child is going to come. Whenever the bottom line is, whenever a child comes back, always check the weight. Check if the baby is going to have has got adequate, not excessive weight loss, and make sure that the baby is feeding well. In our outpatient practice, the best way of getting it done is to get one of our nurses, particularly for guys like us, to just observe feeding. Because for men, it might be mothers may not be comfortable feeding the baby. So always get somebody to observe. Don't trust, again, like what Dr. Samit Dalwa is telling in the morning, just don't believe the history of the mother alone. Always get somebody to observe, and then we would definitely benefit from that exercise. Over to Dr. Adi for, again, another 5-day-old, but here the mom is a well-educated Google doctor mother. Okay, typical westernized Indian mother. So she comes in and complains and says that my child has got loose stools, and you look at it, the baby looks active. So what other diagnostic clue you'd like to want?
this is a very common problem. Previously, any practitioner who's passing loose stools multiple times or in liquid consistency may label as a diarrhea or an infection in the baby. But we should know the concept of transitional stools, as Dr. Kumar told earlier itself. If the baby is active, there is no need to panic at all. The baby is feeding well and active, there is no need to panic at all. We even tell the mothers, ஒரு குழந்தை ஒரே நாலு தடையும் வெளிக்கு போகலாம் அல்லது 4-5 நாளைக்கு ஒரு தடையும் வெளிக்கு போகலாம். ரெண்டுமே நார்மலான குழந்தை நல்லா பால் குடிக்குது, ஆக்டிவா பண்றது. So that reassurance should be given. Next is the description of the stools. Initially, it is sort of meconium, greenish or greenish black, thick sticky stools. Subsequently, it changes to the transitional browning, yellow brownish stools, right? So that phase is typically between 3 to 5 days is transitional stools, and we need not worry too much. However, we should see the general condition of the baby. If there is any clue of sepsis, or say for example, lethargic baby, poor feeding, frequent vomiting, or seizures, or any color change, then you need to worry, give importance to the stools and look for signs of dehydration or infection.
Thank you. So in such as, what are the possible diagnosis which can attribute? I mean, mother wants diagnosis. Condition so what possible diagnosis we can give?
Since it's a Google mother, we can Google back. Tell her that it can be anything right from Crohn's disease to CODs, but you need not bother. You can still reassure the mother that it's more likely to be transitional stools. If at all, the second diagnosis will be sepsis, but this baby doesn't have other features of sepsis, so need not be worried. But if the baby has got multiple episodes of loose stools requiring admission, dehydration within the first few days, then the concept of CODs, congenital diarrheas or the enteropathies will come into picture. But it's a very rare thing. Sometimes we should also not label the child as lactose intolerance. That's a common thing which should not be done, because babies per se will not have enough lactose in their fresh waters. So some amount of lactose carbohydrate intolerance will be there. That has to be accepted. Need not unnecessarily do lactose test to detect lactose intolerance. Right. So for all practical purpose, transitional stools, babies active, continue feed.
Okay. So transitional stools, another one to always keep in mind is yeah.
So this transitional stools, I mean, it's quite common in especially very mothers who are anxious, first time mothers. What they will do is, if baby is crying, they would be offering one side breast. Then even before that side is completely empty, they would offer the other side. Right? So what it happens is the fore milk feeding. So excess of fore milk feeding causes something called as fore milk diarrhea or lactose overload. Okay, so fore milk is rich in water and lactose. So because there is relative lactase deficiency in baby's fresh water, so lactose will not be digested well, so it will be reduced to short chain fatty acids, and this causes a lot of flatulence, perianal erythema, and baby would be keep on crying. So mother thinks that baby is crying for feeds and she continues to feed only fore milk. So we have to break that cycle. We have to educate them that baby is not crying for feeds. You need to space out the feeds and let the baby completely empty the breast, so that this cycle will not become vicious.
Okay, thank you. That's a very important point from Dr. Chandra. So 3 conditions which we need to think of commonly, and conditions which are not diarrhea. One is obviously what Dr. Adi told, transitional stools. Second is the fore milk diarrhea. And the third one is gastrocolic reflex. Please remember that in neonates, the gastrocolic reflex is a dominant reflex. So whenever the baby is going to feed, okay, something is going to come off. Okay, so simple worry they understand. Okay, but then they will not walk still the Google mother, so I have to give something to make sure that she to look for. So there are 3 red flag signs which I normally say. One would be to look for blood in stools. So whenever there is blood in stools, always be worried, bring back the child. Whenever there is abdominal distension, which is severe, particularly if the abdomen looks tense and shiny. And the third thing is, whenever there is vomiting, but then the clue here is to looking for a yellowish or a greenish color, bilious vomiting. So 3 things: bilious vomiting, blood in stools, abdominal distension. And the 4th thing for me to look at is a child who is not thriving well. So those are the things which we have to look for. Thank you very much. Dr. Karthik ரொம்ப சந்தோஷமா உட்கார்ந்துருக்காரு. இன்னும் மட்டும் பேசுறாங்க. So அதனால அவருக்கு அடுத்த கேள்வி. I'll just go on to a very interesting one. Sorry, and then we'll come back to this.
So one more point on that.
Yeah, please go ahead. Yeah, I'll just come back.
So, whenever mother complains of diarrhea, ask them not to put on diaper and ask them to close diapers. And then you can ask them to see like if the water content of the stool, it is more than the stool particle. Now, how much it is more than the stool particle? So if the water content is much more than the stool content as such, then that baby may be having infective diarrhea. Okay. In other causes of diarrhea like this bowel diarrhea, transitional stools and all, the water content in the stool, the soaked diaper may not be, that much. So that is one practical point which will help us to identify babies who are using more water in stools, and thereby they may be having some other causes, infective causes.
Yeah, that's a very practical point, very practical useful point. So thank you very much, Dr. Chandra. So moving on to a hospital. Okay, this is a child who was discharged on day 2. Okay, we are normal delivery, day 2. We are very happy. Mother is very happy. Okay, so decided to take the baby home, but then went home and came straight back saying that my child is having these kind of movements. Okay. So it's fairly obvious what's happening. So anybody from the audience before we pass it on to Dr. Karthik? நீங்க எதை சொன்னாலும் அதுக்கு எதிராக நான் பதில் சொல்ல போறேன். It's not a trick question. It's a fairly simple, straightforward question. Sorry. See here, it's straightforward, simple seizure. Fine, fantastic. Okay, so I'll pass this question. This for Dr. Karthikeyan to comment on it.
The term unit has come the casualty literally from the home after being discharged with this abnormal movements. So we have 2 scenarios when we see the abnormal movements are there. So at that point of time, we are always having a conclusion whether these seizures or benign episodes of benign neonatal myoclonus or tremors, jitteriness, all those. So when a child is when the child is having actively these motor movements are present, at that point of time, we have to note about the autonomic symptoms associated with that, whether hypertension or hypotension, apnea, then desaturation is present with that. And that is usually present with neonatal seizures. And if it is a tremor or jitteriness, that will be with flexion of that particular limb is going to abort that. So that is a very important differentiating feature we can do whenever the child is having actively a seizure. So if the mother is coming with a complaint that she has noted abnormal movements, we have to ask for her whether she's having any recording of videos or something else. And we'll have to observe the child for that particular abnormal movements, then only we can confirm.
Thank you, sir. So when the very useful point here to always remember is given the abundance of mobile cameras these days, almost every time they have a recording. So always ask for one. Secret and but anyway, it's a very useful one. So how do you differentiate between a seizure and non-seizure just by looking at it? The point here, if you look at it, something I'm just going back on it, is you just can look at the frequency. Okay, so different parts having different frequency suggests to me that it's not a jitteriness or a tremor, whereas it's a seizure. That's the first thing to remember. Okay. The second thing is look always into the eyes of such a child when they show you the video. Okay. If the child is going to have abnormal eye movements or a staring movement, okay, or continuous vigorous, like in the Baba is looking at you, staring. Okay, in spite of that. So that is something useful. Of course, that is what the mother history you can take from mother. Of course, if the child is here like this, like sir said, you can look for autonomous phenomena like desaturations, you can look for apneas, you can look for severe usually associated with a tachycardia rather than a bradycardia. So what are the possible reasons a child could throw a fit?
The causes being, the most common causes being the metabolic disturbances like hypoglycemia, hypocalcemia, then the hypoxic conditions during the, whether it would have been in the recent antenatal, that is during the intranatal period, and infections, either intrauterine infections or the postnatal, early onset sepsis or the late onset sepsis, and also the inborn error of metabolisms, either the enzyme deficiencies or the cofactor deficiencies. So rarely we have thromboembolic phenomenon also that can present with urine deficiency.
Okay. And apart from that, there are a lot of common conditions, a huge list. Okay. So, sir, what do you say?
Sir, there are other conditions that can present with abnormal motor movements or benign neonatal seizures. As the name indicates, it's a benign neonatal seizures. Usually the EEG or the imaging which is going to be done in this condition is going to be normal. And also benign familial neonatal epilepsy, where there will be a strong family history. And early myoclonic encephalopathy and early infantile epileptic encephalopathy also can present with persistent neonatal seizures. Then genetic epilepsy syndromes also. In the history, always ask for the seizure onset. What was the day of onset? And what is the type? Usually it will be a focal onset, then proceeding on to a generalized type. And what are the associated symptoms? As we have already told, movement of the eyes, then whether it is particularly associated with fluid discoloration, which is mother has noticed or something. Then ask for a detailed maternal birth and the families.
Thank you. So what would you look for when you're looking for examining this child?
So we go for something called, we can use a vital, abbreviation of STOPS. We can use a sensorium. First is S is for sensorium, then is a temperature, then is oxygenation, then perfusion, then sugars. So with these things, we can see categorize whether the baby is sick or not. So accordingly, whenever the baby is having an active seizure, as discussed previously also, we have to secure two lines. One is for connecting the investigations, other is for simultaneously managing the seizure.
Thank you, sir. So, yes,
and once the seizures are getting controlled, we can do a detailed general examination and the specific neurological examination as well.
Thank you very much, sir. Yes, as we said, even newborns, we can do a complete neurological examination. So always try to examine, of course, when the seizures are controlled. So thank you very much. I'm just going to skip some of those. And then I will ask Dr. Chandra about how would you what are the most important? I mean, I know we planned something else, and because of lack of time, I'm just actually cutting short our discussion. So how would you proceed after all these tests? Which are all the common investigations you would like to do in a child with neonatal seizures?
So basically, I mean, we need to, as a clinician, we need to see what is common, right? Common things are always common. Of course, once we have not found out any common causes, then we will be looking at rare causes. So when it comes to neonatal seizures, always rule out hypoglycemia, hypocalcemia, which are the commonest causes. Okay, transient metabolic disturbances are the commonest causes of neonatal seizures. I mean, in the practice scenario, OPD scenario. Overall, if you see causes of neonatal seizures, then HIE comes. Hypoxic ischemic encephalopathy is the commonest cause. So in the OPD scenario, or in neonate visiting emergency, a well baby presenting with seizures, these are all the commonest causes. So look for calcium, look for sugar, and then go into the history to identify whether any sepsis risk factors are there. Do a proper sepsis screen, complete blood count, CRP. Okay, so these three things should come first. Then subsequently, once you stabilize the baby, control the seizures, you do a proper neurological examination, and then if you are able to identify any other clue for seizures, then you will go for further diagnostic workup. But basic things are CBC, CRP, electrolytes, blood gas, calcium, and sugar.
Yeah, so thank you. So in a primary care level, again, maybe except for blood gas, which may not be available everywhere else, we can definitely get the sugar done, calcium done, a basic electrolytes, and a CBC and a CRP. See, for all its abuse of CBC, it is still a very useful investigations if we know what to look for. So thank you. And then before we move on from this case, can I just ask Dr. Autism how to manage Again, in a primary care, secondary care setup, how would you manage a child who's coming in with a seizure? Your newborn with a seizure, that child we have.
The thing is, if it's a metabolic seizure, the whatever metabolic abnormality has to be taken care first. Without correcting the metabolic abnormality, loading anticonvulsants may not be useful. So for hypoglycemia, 2 ml 10% dextrose followed by the infusion should be the norm. Hypoglycemia, the appropriate infusion should be there. The usual first line anticonvulsant is still phenobarbital. Start with the 10 mg per kg per dose and step with 10. That's the way we go.
So thank you very much. So it's about identifying if it's symptomatic cause of seizure, if it's an obvious seizure like hypoglycemia or hypocalcemia, treat the cause. Without solving the cause, we are not going to get the seizures controlled. Otherwise, it is still phenobarbital. Start with phenobarbital, move on to phenytoin, and then go ahead. And then phenobarbital is a wonderful anticonvulsant. We don't need to give benzodiazepine in a neonate first before giving phenobarbital. That's not something which we do. Unlike in pediatrics, where today morning there's a big discussion about going ahead with the benzodiazepine. Benzodiazepines with phenobarbital in a neonate is always a recipe for a respiratory depression. That's all we need to keep in mind. So the last case, actually we have 8. We are just cutting short at half of it. So because everybody's tired. So this is the last one, which is very interesting. So think of it as a 36-week late preterm baby. Mother is a gestational diabetic mother. And then baby was born, cried beautifully. Namla Kwande good to be Amata baby Kamcho, Amma family la Kamchiter, Kwande Vitu Dandachi. 2 hours later, staff is calling you and telling that this child has got a breathing difficulty. So what do you think is happening here? What are the possible conditions? What other information would you like to know in this child?
Weight of the baby.
Weight of the baby, let's say 2.5 kg. Blood sugar level, yes, blood sugar is 52. Okay, ma'am was the first one to start with. Yes, I would like to know this child has got a normal oxygen saturation. So think of it, and then somewhere first is about is this child really has got a respiratory distress. That's probably the first thing I would like to know. So I'll pass it on to.
So some certain things we need to look into when a baby presents with respiratory distress, especially a newly born infant, right? So one thing is like let us discuss about the risk factors first. So degree of prematurity. So this baby is a 36-weeker late preterm infant born to a GDM mother. Okay, so all these things are important. Okay, because why? Because a late preterm born to a GDM mother can have risk factors for respiratory distress is more. I mean, risk for respiratory distress is more, right? And then antenatal steroids. So if this baby was slightly more preterm, 34 weeks, then mother had received antenatal steroids, then risk of respiratory distress is going to be less. Whether any risk of intra-amniotic infection or chorioamnionitis in mother had fever, high CRP, high leukocyte count, mode of delivery, whether it was normal delivery or is an elective cesarean section without any preceding labor, all these things are important. Any meconium stent liker was there, and whether need for any resuscitation after birth. So all these things we need to look into to identify what could be the cause for respiratory distress. So as rightly pointed out, it is a baby born to infant, the mother with GDM, so blood sugar levels are also important. Then next thing is course of respiratory distress. So whether respiratory distress was there, onset was there at birth, and then whether it is gradually kind of improving, or distress which started mild is worsening over the period of time. So this course of respiratory distress will help us differentiate what could be the cause for respiratory distress. And then one more important thing for clinician is what is the FiO2 requirement to maintain saturation in the normal range. Whether FiO2 required is less than 30% or it is 30% and above. So this will help us to identify the common causes of respiratory distress, which is likely to happen in a baby of this gestation and this size. So when it comes to respiratory distress, we need to have some objective way of assessing the severity also. I think all of you must be aware of this Silverman scoring and Downey score, which we will not delve into detail right now. So our basic intention is to identify how severe it is and whether we can manage with the simplest of the intervention or we need to intubate the baby and ventilate. Okay, right.
Thank you. So can I just ask Dr. Karthikeyan, what are the possible causes in such a child?
The most common causes in the GDM are like the respiratory distress might be due to hypoglycemia. Number one. Number two, it can be due to transient tachypnea of newborn. And as we know, it's a late preterm and also it's a GDM, so there is a risk for a respiratory distress syndrome also. There can be surfactant deficiency in these babies. And other than that, if we go into the details of the maternal history, if there are risk factors for sepsis, we have to definitely consider of early onset pneumonia also in this child. So other thing is, if the Lyca color history is there, we have to rule out MAS.
Okay, thank you. So it could be, see, even though we all assume, I mean, definitely respiratory is the most probable reason why we get a pulmonary causes are the most common cause of respiratory distress. But are there any, Dr. Chandrakumar, are there any non-pulmonary causes which can present with respiratory distress in a 36-week old baby?
So the causes for respiratory distress, there are, it's not only limited to pulmonary. Pulmonary also, it can start from natus to diaphragm. Okay. So anything from choanal atresia, upper airway, malformations, any mass compressing the airways to pulmonary parenchymal problems. So it is a list is, quite long. In addition to this, you can have cardiac causes, metabolic causes, abdominal causes, okay, and then hematologic causes and CNS causes. So all these things can cause, respiratory distress. So let us not discuss all these things in detail, but common things are we need to be able to identify whether this respiratory distress is due to transient tachypnea of newborn or it is due to RDS, that is due to surfactant deficiency, or early onset sepsis, pneumonia, or meconium aspiration syndrome. So chest X-ray, having a radiograph is very important. Should I go to the please? So the commonest cause of respiratory distress in this late preterm group of babies is TTN. So clinically, how you will identify is distress is maximum at birth or onset, and then gradually it comes down over a period of time. FiO2 requirement in these babies are not more than 30%. And when you take an X-ray, you will find a normal or slightly hyperinflated lung with what is called as perihilar streaking or sunburst appearance. What is this perihilar streaking is? Lung is filled with fluid when the baby is in utero. After birth, this lung fluid has to be absorbed into the circulation. So this absorption takes place first through the lymphatics. So this perihilar lymphatics, due to the absorbed lung fluid, appears swollen and distended. So that gives this sunburst appearance around the hilum. Then you may find some fluid-filled interlobar fissures sometimes. These three are the common findings. Okay. Rarely you may find pleural effusion and mild cardiomegaly. But first three things are the common findings. So you may not find all the features in one baby. Like some may have only perihilar streaking, some may have only prominent minor fissure. So these are all different varieties of TTN.
So the point to take home here is that every X-ray when you look at, always look at the lung volume. Okay, so if you're looking at the posterior end of the ribs, okay, so if you're looking at the posterior end of the ribs, if we are going to get at least 8, okay, start counting 1, 2, 3, 4, 5, 6, 7, 8, then you know the volume is adequate. If you're looking at the anterior ribs, at least 6. Okay, so that's probably what we need to definitely look for. And first pointer to remember in X-ray. Dr. Adisham, could this be an RDS? What are the findings which we can look for if it's an RDS?
RDS is basically you get the lung volume is less, right? When compared to TTN, where you get expanded lung pills, it is always small volume lungs in RDS. Then depending on the severity of RDS, you can get different pictures, right? From mild streaking to total opacity, right? So reticular granular pattern, air bronchograms and ground glass appearance can be there. Most severe cases, you will get whiteout lungs. But for whiteout lungs, you should always have differential diagnosis. One is RDS, can be pulmonary hemorrhage, can be PAPVR, can be congenital pneumonia. Depending on the scenario, you need to interpret the X-ray. The other point about TTN is transient tachypnea of newborn, though common cause of respiratory distress, it's always a diagnosis of exclusion. You should know that suppose the baby is born to a difficult labor and having respiratory distress, obviously there could be a CNS trauma, which is HA is the cause for the respiratory distress. Baby born out of meconium stain like with respiratory distress, meconium aspiration syndrome. So the TTN should be a diagnosis of exclusion. Of course, X-rays can help us to certain extent.
Okay, so thank you. Last but one slide about the last diagnosis, meconium aspiration. How common is it in a 36-week-old? What do we find?
Usually in 36-week-older, the meconium aspiration is very rare phenomenon because as the baby reaches term and then only the meconium comes to the hindgut, then the baby passes. But if there is a meconium history in a preterm baby, we have to really consider sepsis of the underlying fetal sepsis, which causes fetal diarrhea leading on to meconium passage in utero, or else if the baby has asphyxia, baby is having some form of difficulty in
Oh, okay, so the findings which you could see here is this reticulonodular opacity. So, and you can see the air trapping in between. There are areas of white out, I mean the blackish, which basically says there is air, and then you see those white out areas. And of course, you can see the hyperinflated lung fins and a narrow mediastinum. So all that put together will say this is meconium aspiration. We are not going to talk about the treatment modalities that because they themselves are a day session discussion. So given that we are run short of time. So thank you very much before we close, anybody wants any questions, any open session. Now we make it open. Any questions to the panelists? I mean, they're brilliant panelists. You can ask them. Anybody, anything in neonatology they want to? Yes, Dr. Sandeep Kumar. Yes.
Then sterilization. Sir, this is actually every pediatrician assessment whoever is attending deliveries, they will be asked like, please give opinion for sterilization. So what we practice in our hospital that we can tell, sir. We tell that as for now, externally there is no congenital abnormalities, no risk factors, baby has been born and normal birth weight is there. So this is the opinion alone we can give. We cannot give opinion for undergoing sterilization. So that is not our responsibility. It is that we go and explain to the parents, telling that your baby is being born term, normal birth weight. At present, the baby is doing well. The baby can be given to the mother's side for feeding. That's all. So with that, the parent, the father and the mother, they have to only decide about sterilization. That's what we are practicing.
See, there's no way we can figure out which inborn error is going to happen tomorrow. There's no way we can figure out which cardiac abnormality is going to present tomorrow. Okay. So as Sir said, all we can say is no obvious gross abnormalities. That's all we can say and nothing else. Okay. So it's something I think my obstetrician hates me for doing that, but it is something we should do for survival.
We should clearly say that doing sterilization is an obstetric decision. We can only state about the baby's condition, present baby's condition.
Okay, so thank you. Raj Chandrakumar on the problem but we face that. So any other questions before we conclude? If there are no questions, then I think the most awaited session of the day is Dr. Rajkumar is waiting.
Regarding vitamin D, sir, almost all babies come out with a prescription for vitamin D for 1 year. So what's your comment from?
So vitamin D has to be supplemented because the vitamin D requirement for a newborn is at least 400 units per day. And breast milk content of vitamin D is very less. Okay. So it's around 4 to 5 international units in 100 ml. So even if you assume a baby is drinking around 160 ml per kilo per day, baby may not get the required amount of vitamin D. So vitamin D supplementation is recommended by all the bodies. Like if you take the classic Academy of Pediatrics, Indian Pediatric Society, all of them recommend 400 units of vitamin D supplementation from birth till 1 year of age. So that has to be followed. For preterm, the dose may be slightly different. Some bodies recommend 400 to 600 for preterm. AAP recommends only 400. ESPGHAN recommends, that is European Society for Pediatric Gastroenterology and Hepatology and Nutrition. That recommends slightly higher dose, up to 800 units. It used to be 1000 units. Now they are reduced to 800 units. So both term and preterm babies require vitamin D.
Probably they require higher dose. Probably Americans require higher dose.
I mean, it's all related to sun exposure also, I understand. Okay, so, I mean, being in tropical country, I mean, we think that we do have a lot of sun exposure, but if you look at the data, that is not the case. So 95% of mothers are deficient in vitamin D. And if you test vitamin D levels in newborns, they are also deficient. So let us assume that we have to continue. I mean, the pattern across the globe is same.
So there's a lot of sun. There's a lot of sun. Our babies don't get exposed to because, see, our babies get exposed to sun for the wrong reason. Basically, treatment of jaundice and solitaire, which is actually basically frying the baby, another host of the baby. But yeah, but otherwise, genetically also, we are not good at converting the sunlight exposure to vitamin D. There are a lot of genetic studies which have shown it. So our ability, in fact, to convert the sunlight, synthesis vitamin D from sunlight is far worse than the Caucasians. So even though we have a lot of sunlight, it doesn't mean we are going to get a lot of vitamin D, number one. Number two, as I said, it's about maternal vitamin deficiency. Nearly 50% or even more mothers are vitamin D deficient. அவங்க கொடுக்குற பால் தான் குழந்தை கிடைக்குது. So அதனால vitamin D deficiency is definitely a problem. Number three is vitamin D, please remember, it's a pro-hormone, which is useful, I mean, which has a lot of positive effects in the growth of the baby. And so at least for 6 months, 1 year, yes, again, we can find out, but 6 months, definitely, minimum 400, SAR get our NA probably from day 10 of life. Where the reason for day 10, there's no lot of science to it. Probably more a practical reason rather than anything else. Allow the mother to breastfeed first. Let the baby get used to the breast milk before you introduce something else. Probably that's the only reason.
Yeah. How long we have time? You see, milk is fortified as you okay, here our milk is not fortified.
Fortified with water.
Whenever I test my vitamin D levels, always it is less. And even though I'm not vegetarian, okay, I eat a lot of non-vegetarian food, but still my vitamin D is less than the recommended level. So probably it is there, and we need more vitamin D.
Okay, go. Yes, sir, please.
Vitamin D is a misnomer. Because all the time now people only talk about vitamin D from an endocrine point of view. Now it becomes directly of endocrine
Yes, sir.
rather than from nutrition. And because it is the term vitamin D is a misnomer, I think that is number one. Number two, is also we keep getting scared about hypervitamin that is
also quite common, sir. Hypervitaminous D is quite common. There is some association between vitamin D levels and severity of asthma and all. So people started prescribing vitamin D, without even checking the levels, and a lot of babies have landed up with hypervitaminous also. So we have to be careful when you are using these bolus doses of vitamin D. You have to always check vitamin D levels before prescribing.
I recall there was a paper which you published on
Yes.
when you are doing a deal.
Yes.
So can you just share?
That was actually a randomized trial on two different doses of supplementation, 400 versus 800 units in preterm babies, and then looking at the levels of vitamin D. So in that, what we found out was 800 units per day was kind of more useful in preterm babies, because vitamin D deficiency levels at 40 weeks corrected term age and as well as at 3 months follow. In 800 group, they fared better.
So, okay, thank you very much. I hope we have had a useful interaction. So let's move on to something else actually today. Dr. Rajkumar and his quiz for pediatricians. Yes, sir. Oh, yeah, sorry, I forgot. Okay. Right about light now, but you have to cut
I still come to felicitate Dr. Tirumurugan sir. I request Dr. Shankar, Organizing Secretary, to felicitate Dr. B. Adishan. I request Dr. Vinod Kumar, Treasurer and IIT Pondicherry, to felicitate Dr. N. Chandra Kumar. Dr. Johnson Reddy, Secretary IIT Pondicherry, to felicitate Dr. K. Karthikeyan. Coming to the last session, I request our quiz master, Dr. P. S. Rajkumar, to come to the dais. Let us start with the quiz for Dr. V. Namachivayam medal. I request Dr. V. Namachivayam to chair the dais.
இல்ல உன் லேப்டாப் எடுத்துடணும் உன் லேப்டாப் எடுத்துருவேன் ஏன்னா அதுதான் நீங்க இது பண்ணிருப்பேன் ஓகே இந்த குவிஸ்ல வந்து எல்லாருமே பார்ட்டிசிபேட் பண்ணலாம் so we request everybody to participate so the link வந்து will be projected right now so you just need to open up your website sorry your browser and click on the link put your name and then start answering so after each question Dr. Rajkumar will tell the answer there are 4 prizes to be won 2 for postgraduates 5,000 rupees first prize second prize is 2,500 and another so உங்க பேரை போடும்போது பின்னாடி போஸ்ட் கிராஜுவேட்டா பீடியாட்ரிஷியன் போடணும் அப்போ போஸ்ட் கிராஜுவேட்ஸ் எல்லாரும் பீடியாட்ரிஷியன் போட்டீங்கன்னா ஒத்துக்க மாட்டோம் எங்களுக்கு தெரியும் யார் போஸ்ட் கிராஜுவேட் யார் பீடியாட்ரிஷியன் and
லிங்க் வந்து
இது group name போட்டுறோம் சார்
the link will be given in the group also delegates group.
Okay. So before that, we want to this particular quiz has been the idea from the Kadalur team who want to name it in the honor of the senior most pediatrician of one of the senior most pediatrician of Kadalur, Dr. VN. So just for introduction of Dr. VN. Sorry. Just one second.
So on behalf of IAP Kadalur chapter, we are proudly presenting our doyen எங்களுடைய சிவனும் அவர்தான் சீவனும் அவர்தான் ஒரே வார்த்தையில சொல்லலாம். He joined Tamil Nadu Medical Service in 1967. Worked as an assistant surgeon for 7 years in DME side and 7 years in DMS side. He worked in Government Headquarters Hospital, Kadalur, and he started all OPV vaccination and other target hospitals. And he managed JE encephalitis epidemic effectively and was appreciated by the Tamil Nadu government then. So he was a life member of 1987, and he was a founder president of IAP Kadalur in 1990. He is a great academician, very interested in academics. He was the person who started IAP Kadalur, and he has motivated us and all of us. He has galvanized us. He has been a role model. He has been so humble and so accommodative. தட்டி கொடுத்து நம்பிவா செய்யுதசி அப்படின்னு சொல்லக்கூடிய ஒரு அருமையான பர்சனாலிட்டி எங்கள் மாவட்டத்துல அவர் பெண்ணாடத்துல இருந்தாலும் கடலூர் மாவட்டத்துல இருக்கிற அத்தனை குழந்தை நல மருத்துவர்கள் மட்டும் இல்ல நோயாளிகளும் அவரை போற்றினா அவர் தூக்கி வச்சு தெய்வமாக கொண்டாடுபவர்கள். ஆக அவர் பேர்ல இந்த விருதை நாங்க கொண்டு வரணும் அப்படிங்கிறத நினைச்சு முதல் முறையா we are doing it as the first medal on behalf of Dr. V. Namachivayam. We are really proud in instituting it on behalf of his name. Let us honor, sir.
request my sincere thanks to all of you. The பெரிய இது நான் உடனே பண்றேன் கவர்மெண்ட் சர்வீஸ் கவர்மெண்ட் சர்வெண்ட்
சிவபிரகாசன் பிரதமர் 2 பேரும் சார் சிவபிரகாசன் பிரதமர்
with all sincerity I was doing my duty in the government service. That only has fetched me good name in the government as well as among the people. அவ்வளவுதான் பெரிய ஒண்ணும் இல்லை. மோஸ்ட் இம்பார்ட்டன்ட் திங் இந்த அக்யூட் டிசபிலிட்டிஸ் சமயத்தில் வந்து நல்ல எஃபெக்டிவா மேனேஜ் பண்ண அந்த சமயத்தில் நிறைய கேஸ் வரும். வருஷத்துக்கு 200 கேஸ் வரும். ஆல் கேசஸ் ஆல் ஹாஸ்பிட்டல்ஸ் டு கவர்மெண்ட் ஹெட் குவார்டர்ஸ் ஹாஸ்பிட்டல். அப்போ கம்ப்ளீட்டா புரோஃபார்மா போட்டு கம்ப்ளீட்டா வர்ற கேசஸ் பூரா எல்லாம் இன்க்ளூடிங் பிரெயின் பயாப்சி டெட் கேஸ்ல பிரெயின் பயாப்சி கூட எடுத்து தட் வாஸ் ப்ரூவ்ட் ஆஸ் acute Japanese sensibilities. அந்த எங்களுடைய இதுவும் பிளஸ் அந்த சேம் டைம் வந்து வேற ஒரு சீரியஸ் ஹாஸ்பிட்டலும் பண்ணாங்க. இந்த 2 ஸ்டடியும் போய் தான் வந்து ஜப்பானீஸ் சென்சிபிலிட்டிஸ் நேஷனல் கவர்மெண்ட் ஆல்சோ என்னுடைய பேப்பர் வந்து சர்க்குலேட்டட் ஆல் ஓவர் இந்தியா அட் த டைம் டு ஆல் தி 12 ஹாஸ்பிட்டல்ஸ் இந்தியா. அந்த மெடிக்கல் காலேஜ் பேப்பர் தான் வந்து சர்க்குலேட்டட் ஆல் ஓவர் இந்தியா ஃபார் அந்த ரோல் மாடல் மாதிரி எல்லாம் வாட்டர் அப்படிங்கிறது. நெக்ஸ்ட் சிஸ்டம் வந்து ஆஃப்டர் 2 years ஆல்சோ இட் வாஸ் கண்டினியூயிங் ஃபார் மோர் தென் 5 years. இப்போ வந்து அதுக்கப்புறம் வந்து எபிடமிக் வரும்போது டைரக்டர் ஆஃப் இன்ஸ்டிடியூஷன்ஸ் ஐசிக்கு தெரியும் அங்க இருக்கிற டைரக்டர் வந்து நீங்க போய் அதை இன்ஸ்பெக்ட் பண்ணி வாட் இஸ் ஹேப்பனிங் சொல்லும்போது டைரக்டர் டாக்டர் B.R. சந்தானகிருஷ்ணன் வாஸ் தேர் அட் த டைம். அவர் கவர்மெண்ட்டுக்கு எழுதினாரு அங்க இருக்கிற பீடியாட்ரிஷியன் டூயிங் எக்ஸலன்ட் ஜாப் தேர் இஸ் நோ நீட் டு கோ தேர் ஃபார் இன்ஸ்பெக்ஷன். இந்த இது வந்து போர் பண்ணி ஹெல்த் செக்ரட்டரி அட் தட் டைம் வாஸ் தேர் சென்னை. He gave me a special certificate. We want the people like you in the government service, no certificate that it was பெரிய பூத்மா இருந்தது. கவர்மெண்ட் சர்வீஸ் வேலை செய்ய முடியாத நிறைய வேலை செஞ்சு